Well, hello, everybody, and welcome. Thank you for joining us today. Whether you're watching it immediately live today, November the 12th at 5:30 p.m. Eastern, or watching a rebroadcast, welcome to the International Myeloma Foundation's virtual regional community workshop. And tonight, I'm surrounded by all these people from Cleveland, including some amazing people from Cleveland Clinic that I'll introduce shortly. My name is Joe Mikhael. I have the privilege of serving as the Chief Medical Officer of the IMF, and I'm also going to be your host tonight. We remind people right off the start, we want your feedback about how this program goes and how it resonates with you. You'll see the opportunity at the end to complete a survey, and it really does formulate what we do. I can tell people that we're going through the process right now of refurbishing a lot of our educational programs, and so much of that is based on your feedback. So please do that at the end. We want to take a moment to thank our sponsors who make these workshops possible, from AbbVie, Amgen, Bristol Myers Squibb, GSK, Johnson & Johnson, Karyopharm, Sanofi, and Takeda. We appreciate their support. So this is what's going to happen over the next 3 hours or so. I'm going to have a little bit more introduction, and then I will provide the Myeloma 101 talk. I always say, no matter where you are on the myeloma spectrum, if you're brand new to this disease or if you've known it for many years, going back to 101 is helpful because it helps you not only understand it, but convey it to others. And then we have the world famous Beth Feynman, who clearly has very, very few degrees after her name. She's got more degrees than a thermometer, but she will be, she's a nurse practitioner at Cleveland Clinic, and she's going to tell us about what is entitled Life is a Canvas, You Are the Artist. If you're intrigued by the title, wait till you hear the talk. And then thereafter, Frontline Therapy will be covered by Dr. Lou Williams, who is a good friend and another wonderful physician from Cleveland Clinic. And so we're thankful to have him join us tonight. And then really the heart of these sessions after these talks are to have a lot of opportunity for Q&A. We did a virtual workshop last month, and I think we had just short of 100 questions in the Q&A. So it's going to be like rapid dating. It's going to be a rapid fire round. We're going to answer questions quickly. I promise Beth I'll give her all the really tough ones. We'll take a little break, and then Lou will continue his talk in the early phases of treatment, talking about maintenance therapy. I'll talk about relapse therapy and clinical trials, and then again, we'll have plenty of time for questions before we wrap up at 8:30. So you'll have time to take a little break in the middle of it and hopefully bring your questions forward. This is one program that is part of a massive support network that the IMF seeks to provide. This is our core IMF support team here. These are just really incredible people dedicated to the care of myeloma patients. We have over 150 support groups across the country, as you can see here, with just about every single state represented. If you have questions, you want to learn more, you can reach out either at myeloma.org or support.myeloma.org, or as an email at the SGT team at myeloma.org. Particular of interest, we have not only geographical groups, we have a number of support groups that are designed to help individuals in different ways, like Las Voces, which is done in Spanish, that I know Dr. Williams has assisted with because he is fully fluent in Spanish as well. We have individuals who maybe do not have a care partner in the Living Solo program, the Smolder Boulder group with those who have smoldering myeloma, myeloma families for those who have families, care partners only, and even more recently, we created a myeloma support group for those with high-risk myeloma. So you can learn more about these at myeloma.org, but if that resonates with you, feel free to do that. Furthermore, we have just launched in the last several weeks, maybe one of the coolest things I've ever seen the IMF do. We have our own chatbot. His or her or their name is Milo. And if you go to myeloma.org, Milo pops up in the corner, and you can ask Milo anything. You can even ask them, who is Beth Feynman? Who is Lou Williams? But it's focused on what we provide at myeloma.org, and it's there really to provide empathic support and educational and intellectual support in all of the phases of myeloma. So please take care of, take time to go to the website, check out Milo, and ask questions. It's a really remarkable AI-powered chatbot that we've just introduced. The other partnership that I want to mention very quickly that I'm particularly excited about is we have partnered with the organization called Spark Cures to really provide an opportunity for individuals to learn about clinical trials. And when you go to this it's right there on the myeloma.org. Everything you hear today, you can get at myeloma.org, can direct you to clinical trials that are available in your area or across the country. If you wish to travel, you can personalize it by saying relapse myeloma or frontline myeloma or other particular features, how many lines of therapy you've had, and it can provide that personalized support for you. So lots more at the end about the resources available to us, but let's dive right in now and talk about Myeloma 101, as we call it, as we try to think together a little bit about what is multiple myeloma. So my plan over this next period of time with you is to think about the basics of blood cancer. What is myeloma? What are the staging and classification? How do we think about treatment, knowing that Dr. Williams is going to walk you through frontline therapy, and I'll talk about relapse therapy later, but just give you the concepts behind treatment. And then we'll talk a little bit about health disparities, because myeloma is the most disparate cancer within the African American community. So myeloma is not a very common disease. I mean, we estimate this year about 36,000 new cases. Tragically, we also expect about 13,000 deaths. So it accounts for just under 2% of all cancers. The average age of diagnosis is about 69, but as I'll share with you later, it's considerably younger in the African American and the Latino American population. Slightly more common in men than women, but also twice as common in the African American population. So individuals like myself of African descent, we're at twice the risk of getting multiple myeloma when compared to those who are not. We'll talk a little bit more later about outcomes and survival, but you can see in that how common is myeloma, that myeloma is about 14 in the list of cancers. And you can see that the vast majority of patients are diagnosed between 45 and over 84. Very few patients are diagnosed at a much younger age, although I just saw a patient in my clinic today who was diagnosed in her 30s. So one of the challenges of myeloma is that people don't show up to the office saying, "Hi, doc, I've got myeloma," or "I feel this lump," or "I have this particular symptom." It often starts with very general symptoms like being fatigued, like having bone pain, and very often in the back, or if a blood test is done, and I'll review what this is in a moment, that someone has a low red blood cell count or anemia. And this is a challenge because very often this is where people get found, but lots of other diseases cause fatigue, bone pain, and anemia. And so it's often hard for the primary care doctor to say, "Oh, I should be thinking about myeloma right now." And so part of these programs are to help us identify that and understand that. Part of the work that I do at the IMF in our Empower program that I'll describe later, which is designed to improve the outcomes of African American, Latino American patients who've historically had very poor outcomes with myeloma, is to catch the disease earlier. And very often there are confounding diagnoses like diabetes. Diabetes is often the great mimic in myeloma, because these three things, for example, can happen in diabetes, and someone may not appreciate the fact that they may actually have multiple myeloma. What causes myeloma? The short answer is, for the vast majority of cases, we do not know. There's no clear association with most patients that we have with myeloma. Certain cancers, of course, are very much associated with smoking or other exposures. We don't have that to the same extent. That being said, we do know that there are certain things that can be associated with it. In particular, our veterans, for example, who have been exposed to Agent Orange, our firefighters and first responders who have been exposed to multiple fires. There is some connection to radiation exposure, which we also see in other cancers. When it comes to an individual, as I showed you earlier, myeloma is more common as we get older, so that's a risk factor. Obviously, being of African descent, as I noted before, there is also a connection to obesity, although we fully don't appreciate it yet. We don't really understand all that's implied and that is meant, understood by that, but there is a connection to that. And then, of course, if someone has a history of so-called MGUS or smoldering myeloma, which I'll describe in a moment, which is if you think of it as a pre-myeloma condition or a precursor condition to multiple myeloma. But let's go back to the basics for a moment. What is blood? Because we talk about myeloma being a blood cancer or a bone cancer. It sometimes doesn't make sense to people. I remind everybody that we have three kinds of cells that circulate in our blood: what are called red blood cells, what are called white blood cells, and what are called platelets. I remember them as red, white, and rosé. That's often the easiest way to remember them. So we have red cells, we have white cells, we have platelets. Red cells are really the red trucks that carry oxygen in our body. So you breathe in oxygen and the red cells pick it up and deliver it to the tissues. The white cells are a bit more complicated. They really form our immune system, and platelets, or the rosé cells, are just little cells that help us clot. The white cells are the ones we're particularly interested in because one of the cells that live in our bone marrow, not in the peripheral blood, but in the bone marrow that makes our blood, are called plasma cells. And myeloma is a cancer of the plasma cell. Well, what is a plasma cell? A plasma cell is a cell that makes antibodies. So normal, good plasma cells make antibodies. I can almost guarantee you that sometime in the last 6 or 8 weeks, both Beth and Lou went and got their flu shot. I'm hoping to see some head nodding. Okay, good. So they both got their flu shot. So what happened when Lou got his flu shot? Well, someone stuck a needle in his arm, and that needle put substance in his arm that sends a message to his plasma cells. And it says to his plasma cells, hey, plasma cells, listen up. This is what the flu looks like. I want you to remember it. So if you get exposed to the flu, you know how to fight it. And the plasma cell responds by making those antibodies towards the flu. And, in medicine, we love to use words that patients don't understand. So we call them immunoglobulins, but they're basically antibodies. They're a kind of protein that can fight off the infection. Sadly, what happens in myeloma, those same plasma cells that should make good antibodies, that should fight off infection, now they're called clonal or abnormal plasma cells, and now they make abnormal proteins and abnormal immunoglobulins, abnormal antibodies that can go and attack the kidney and that can attack the bone. And based on the type of plasma cell that becomes cancerous, we have different kinds of immunoglobulins or antibodies. We have what's called IgG, IgA, IgM, IgD, IgE. I'm not going to get you to worry too much about those. Most commonly, patients either have IgG or IgA myeloma, but these antibodies are made up of what are called heavy chains and light chains. And actually, even 20% of myeloma patients only have light chains in their myeloma. And so the way we detect typically myeloma is a fancy schmancy blood test where we actually detect these proteins. These, very importantly, are not the kinds of blood tests that are typically done by a primary care doctor. That's one of the reasons why we don't detect myeloma early on, because these are fancier tests that are not typically done when we first measure them. And as I noted before, myeloma actually is part of a spectrum of things. So if we look at the far right, what's called active multiple myeloma, that's what we're refocusing on tonight. Which means if I look in someone's bone marrow, they have more than 10% plasma cells. Normally, if I looked into Beth's marrow tonight, not that I plan to do your marrow, Beth, but if I looked at Beth's marrow tonight, I should maybe find 1% to 2% plasma cells. We might even accept up to 5 being normal. But when it gets over 10, there's clearly a signal. And those patients definitely have what we call a myeloma defining event, which basically means, as I'll show you in a moment, that damage is happening to the body because of these high levels. But very importantly, we have these two categories before myeloma, because even though myeloma is relatively rare, the precursor conditions to myeloma are actually incredibly common. As we get older and we keep making antibodies, and every time we get our flu shot and every time we get exposed to something, we're constantly making antibodies. We got to cut our immune systems a bit of slack here. Be easy on your plasma cells. As we get older, sometimes the plasma cells make some abnormal protein. It's not a big deal. It doesn't really do a lot of damage. It's just a little bit of it. But we know that if that keeps happening, it can actually ultimately become myeloma. Sometimes I've said it, even though we always get myeloma and melanoma confused as a skin condition, I say it's like all the moles you might have on your body. The vast majority of them are probably not a big deal, but there may be some that can actually become cancerous, and we need to watch them a bit more closely. So it's actually common. 5% of everybody over the age of 40, if we look for it carefully, can actually have this thing called MGUS, or monoclonal gammopathy of undetermined significance. That just means you got this little schmutz of bad protein, but it's not damaging anybody. If we do a bone marrow, you don't even have 10% plasma cells, and the likelihood it's going to grow is only about 1% per year. Then lastly, we have this middle category, something called smoldering myeloma, where we do a lot of research these days, where we actually see more growth than the MGUS, but it hasn't crossed the line to become active myeloma. And that's an area where I saw a couple of patients today with smoldering myeloma, where we are looking very carefully at these patients because their risk of growing to myeloma is about 10% per year. It goes down a little bit with time, but that's a pretty high risk of becoming myeloma, and we don't want to miss it happening. And that's why you may hear some of those terms tonight as we go through. Well, what are those myeloma defining events? What tells us that someone has damage to their marrow, to their body? They have at least 10% plasma cells in the marrow, and they have one of these 7 things. Historically, we always talked about the 4 on the right, the crab, the high calcium, the renal or kidney damage, the anemia or the low red blood cell count, or some kind of bone disease because it attacks and thins and sometimes even breaks our bones. But we've also learned that if there's more than 60% plasma cells in the bone marrow that are clonal, that tells us that badness is coming, so we need to do something about it. Those light chains I talked about, people have those immunoglobulins. Sometimes we have just the light chains or the light chains in addition. If those light chains really build up, and we can measure them, what's called the ratio, the if you will, the bad light chains over the good light chains, if that goes over 100, or if someone's actually had an MRI of their bone marrow and we see little pockets of growth, because normally our bone marrow is kind of like a simple, a smooth soup of growing cells, but if there's lots of bubbles going on in there and it's boiling over, something bad is going to happen, and that is technically how we define multiple myeloma. So that's why myeloma involves a lot of blood tests. We look at those basic, what's called CBC, or complete blood count, where we look at the red, white, and the rosé. We look at the chemistry or the complete metabolic panel of people, and then we do all the fancy tests. I'm not going to read every one of them to you here, but for those of you who are on the myeloma journey, you're learning about how important this is to know what is my protein level, what is my M spike, or that abnormal monoclonal protein. You know, if I see a patient that has lung cancer and we measure their lung tumor to be 10 centimeters, that's the starting point. And we hope as it gets treated, it goes down to 8 and to 4 and to 1 and disappears. Well, for myeloma, we don't have necessarily a simple tumor to look at, although sometimes we can have pockets of clumps of plasma cells. We look at the blood test. We look at that M spike. We look at that light chain level. And as someone's being treated, we see that go down. And later on, I'll show you depth of response. And Dr. Williams will be explaining to us a little bit about the treatments that we give and what fraction of patients get into response that we define as at least cutting that number in half. We think that if you cut that number at least in half, and hopefully even more, that's a sign that a particular treatment is working. We also do imaging for myeloma. In the old days, we used to just do simple x-rays. We really don't do that much anymore because it's not very sensitive. You have to have a lot of damage to your bone for a plain x-ray to pick it up. But these more sophisticated tests like CT scans and PET scans and MRIs can look carefully, because what happens is the balance that you and I have to keep our bones strong gets lost in myeloma. And the bones start to get thinned and can even break. And that's why, as you see in the pictures, we can even have compression fractures in our bone. Ultimately, the blood tests are helpful, but definitively, we have to find those bad plasma cells. And we do that in the bone marrow test. And again, we could spend a lot of time explaining this, and I don't want to make it complicated. But when we do a bone marrow test, we're really looking for 2 very important things. Number one, what percent of plasma cells are occupying the bone marrow? Because remember, it's not really myeloma unless it's over 10%. And sometimes it can be considerably higher than that. But we also want to know a little bit about the plasma cells. It's one thing to say, I have this many enemies, but I want to know, if you will, how evil those enemies are. And what we do is we evaluate the genes of those plasma cells. Now, these aren't the genes you've passed on to your children or received from your parents. These are the genes of the cancer cells that have mutated and that have gone off the rails. So I think that's always an important distinction to make, because sometimes people get confused by that. But we can get a sense by looking at those genes, how dangerous is the kind of myeloma? And we typically put people into 2 categories. Do you have what's called high-risk myeloma or standard risk myeloma? About 25% of patients have high risk, about 75% have standard risk. And this makes a difference because it might influence our treatment or our aggressiveness of treatment, because unfortunately, high-risk patients tend to have more aggressive disease. It tends to come back quicker. Listen, when I started in myeloma, Lou was in utero, Beth was in diapers. When I started in myeloma, sadly, most of my patients did not live more than a year and a half with myeloma. It's actually one of the reasons why I went into myeloma, is I wanted to take care of patients who were really, really sick. Now, the average patient with myeloma diagnosed today is going to live more than a decade, which is wonderful. One of the areas that we still have to work on is this high-risk myeloma, because those patients unfortunately tend to have a bit of a shorter survival, probably in the range of about 5 years. Now, that's based on what's happened up to now. I think we're going to do a lot better over these next 5 years with all these great new treatments we have. But that's one of the reasons why it's important to distinguish high risk versus standard risk. Now, the problem is myeloma doctors in the myeloma community, we're pretty much geeks. And so we have all these different scoring strategies and what's high risk and what's not. This is a bit of an alphabet soup here of different things. We have what was originally called the ISS, the International Staging System. Then someone came along and revised it, made it the revised ISS. And then now we have the R2 ISS, and we're about to make an R3. So I find this very confusing for patients to remember. That's why I tend to keep it simple and say, we typically divide people into standard risk and high risk. And that high risk feature has a lot to do with certain genetic things that goes beyond the focus of what we're looking at today. But if you look on the right hand here, where it says putting it together, the most common features of high risk are 1Q plus, which means an extra copy of the Q portion of your chromosomes. You have chromosomes, you get one from each parent. You have 23 of them, so you got 2 copies of each. And every chromosome has what's called a P arm and a Q arm. That's where you get the expression, mind your P's and Q's, if you're old enough to remember what that was. And if we have an extra copy of 1Q, that tells us that there's potentially high risk. If someone has a deletion or absence of the P arm of chromosome 17, because there's a really important gene that lives there, or if they have what's called a translocation, which just means one piece of one chromosome joins with another piece of a chromosome, they get together when they're not supposed to get together. And in this case, if a piece of 4 and a piece of 14 get together, that's considered high risk. As we think about treatment, and in a few minutes, I'm going to turn the mic over to Beth. But before I do so, let's spend a little bit of time talking about treatment and then disparities. We typically still generally divide people into this category. Are you eligible or not eligible for a transplant? Dr. Williams will talk more about this in a few minutes, but we generally make that distinction because we've learned that this modality of giving someone a stem cell or bone marrow transplant can actually be very effective and really help keep the disease in remission. It is not curative, but it can keep people in remission. So we often give someone an initial treatment. We may or may not give them a transplant, and then we give them ongoing treatment or maintenance therapy because we've learned if we even just give baby amounts of treatment to keep the disease down, it keeps it away. Inevitably, and unfortunately, this is not yet a curable disease. Everybody's disease will relapse, and I'll talk more about relapse later. All the while, we take care of the whole of the patient. I say it all the time. I don't treat myeloma. I treat people, and we need to look at them like that. And so it's important that you're engaged and involved. The fact that you're listening to this workshop, I'm already kind of preaching to the converted, is that you want to take ownership of your disease. We have so many tools, as the ones are in the top-hand corner there, about questions to ask your doctor, a tool that'll help you in that discussion so you don't feel that you're just sitting on the sideline. Because, wow, do we have choices that we never had before. When I made this slide nearly 20 years ago for one of the first talks I ever gave in myeloma, I had 2 words on this slide, or 2 drugs on this slide. Now we have all these different classes, and the slides are provided to you for later if you wish them. I'm by no means going to walk through all of this, but I just wanted to literally overwhelm you with the number of choices that we have. We have all these different classes of drugs that we use now, both on this first page and this second page. And then what we call the pipeline, which means there is so much more coming. I don't think in 20 years of myeloma research that I've had the privilege of being involved with, I have ever seen as many drugs to come as we see now in the toolbox that we have. As I noted before, as we treat people, we want to get them down to a deep response as much as possible. And we have now this best category of response that you might hear about tonight called MRD, or minimal residual disease. This is where we can't even find any evidence of that bad protein and of those bad plasma cells. And that's our goal. That's not necessarily cure, because it could still come back, but that's our path to cure, to getting people into the deepest response possible. as I noted before, we have to think sometimes about when someone gets treated, because there is that spectrum of MGUS to smoldering to active. And even once someone has had active disease and we're watching them, the very first time we see a little bit of protein, we may not immediately jump on it. We have to ensure that the disease is truly growing. If obviously someone has disease that is active already, then we definitely need to start to retreat them. And the treatment, as I mentioned, is amazing. And you're going to hear later in my talk on relapse about what all these license plates, as I call them, sound like. They all seem to be like license plates, or I was giving this talk in Canada this weekend, and I said they're like Canadian postal codes, if you're familiar with them, mixes of letters and numbers, and it's hard to remember what it means. But what this picture is meant to show you is that we have all these different targets on the outside of a myeloma cell. And it's really amazing how we've been developing drugs to target those. And so we'll be talking over the course of the day today of these antibodies that hook onto the myeloma cell and trigger the immune system. What are called bispecific antibodies, these drugs that have two arms, that's why they're called bi. One arm hooks onto the myeloma cell, the other arm hooks onto one of your own immune cells and activates it. Or this concept of CAR T-cell therapy, which is really remarkable. We have something called antibody drug conjugates, these drugs that hook onto myeloma and they kind of have a toxic backpack that they drop into the myeloma cell to trigger the cell death. We have CAR T-cell therapy, which if you told me about this 10 years ago, I would have thought you were cracked because it sounded like a Star Trek movie. But it's amazing. I can actually take T cells or immune cells out of a patient and train those cells to have the ability to attack someone's myeloma and then give them back to the patient and even multiply them as I do that. It's really a remarkable thing, and it has really changed the way we think about myeloma. And then, as I mentioned, we have these bispecific antibodies, these drugs that hook on to both a myeloma cell and a local T cell and activate them. And the cool thing about these bispecifics is I don't have to go through the whole process of collecting someone's T cells and manufacture them and waiting for weeks to come back. I can just take this right off the shelf and treat a patient with it. I mean, it really is amazing what we're doing. And this slide is overwhelming, and it's meant to be overwhelming, because what this slide shows to us is that we have more drugs than we've ever had before and a whole lot more coming. I love updating this slide because it really is amazing how much has evolved in the field of multiple myeloma, and you'll hear more about that, of course, over the course of the night. We're not there to cure yet, but we're closer than we've ever been before. We haven't cured diabetes or high blood pressure. We control it in the long term, and I think we are really making a headway. A couple of final comments before I turn it to you, Beth, is that one of the things we believe strongly at the IMF is that you have the right to a second, or sometimes I prefer the word expert opinion. Second makes it sound like the first one was wrong. And it's not to counteract what the first doctor or team said. It's to support you with someone who is in the middle of myeloma day and night, to confirm your diagnosis, to give you more options, to be able to guide you as you go through your treatment journey. One of my last slides here is a call to action. The whole concept of health equity is not something that's new. It's something the IMF has been working in for 30 years. But one area which is particularly concerning is within the African American population, where myeloma has really been a challenge for these facts reasons. We'll walk through them very quickly. As I mentioned before, most patients have a long time before the diagnosis is made for all sorts of reasons. It's even longer in African American and Latino Americans. They're younger on average by age of diagnosis. I already mentioned that myeloma is twice as common in that population. But unfortunately, a Black man or a Black woman diagnosed today is expected to live half as long as the same aged white man or white woman. And why is that? A lot of it has to do with delayed diagnosis or lack of access to treatments. You're going to hear tonight about 4 really important treatments that over the last 20 years have improved survival in myeloma: transplants, triplets or drug combinations, clinical trials, and CAR T-cell therapy. Interestingly, some might say, oh, well, maybe African Americans do less well with myeloma because they have more aggressive myeloma. Actually, that's not true. African Americans are less likely to have high-risk myeloma or more likely to have standard risk myeloma. And we know when given equal access to therapy based on lots of studies, that we can actually see even better outcomes. So the IMF has created what's called the Empower programs, a bit of play on words, to empower, or Myeloma Power, to empower communities and patients to change the course of myeloma. And we do it in three ways. We engage the community, we educate primary care doctors, and we seek to enhance the care of myeloma patients. And in that engagement, we go to churches, fraternities, sororities, community centers. We even had one of the screens in Times Square with Ice-T, who allowed us to do a video with him to raise awareness of multiple myeloma. We did that for the first week of Black History Month. We want to get the word out, and we want patients to be diagnosed earlier and to be treated more effectively with this terrible disease. You can learn so much more at myeloma.org. We have a ridiculous number of resources available to you, including these booklets and other things that can take you in much more detail of what I've given you just as a very general overview. So with that, I will stop, and I just will remind everyone that we really do love your questions. I see a whole series of questions already coming in. Please enter your questions in as you watch this, and we'll take time before the break to answer a lot of those questions. With that, I will turn it to my very dear friend and colleague, whom I care about very deeply, Beth Feynman, to talk to us about life as a canvas and you are the artist. All yours, Beth.
Thank you so much, Dr. Joe, for taking us on that journey of how somebody is diagnosed with multiple myeloma. I am so fortunate to be surrounded by these brilliant people on the call here, and I'm seeing all these great questions in the chat, so don't forget to put all your questions in there. In about the next 15 minutes, I'm going to take us through Life as a Canvas and You Are the Artist. I'm a founding member of the Nurse Leadership Board. I started in 2006, and each year we try to have some catchy little ways to present some of our material. And so this is what we're going to be presenting tonight. The objectives are to color the wheel of your treatment, framing your care, and live life in color. It was either this or the horse presentation. I'm not in Phoenix this weekend, so I thought this would be more appropriate. So coloring the wheel of your treatment. So we heard about how one is diagnosed with myeloma. And when you're diagnosed with myeloma, it's not just the myeloma treatment, it's also the supportive therapy. So first and utmost, the goal is a rapid and effective disease control, but we also want durable disease control. You're going to be hearing from Dr. Williams later on about the maintenance therapy we use, the initial therapy that we use, and then we're going to hear about the therapy at the end. Many of you want to stay in remission and never have to take another treatment, but fortunately we have other treatments to give you. Dr. Joe likes to pretend that he's much older than I am, but we're the same age, number one. And number two, I started doing this in 1994 when we had no good drugs to treat myeloma. So I'm so pleased to have been part of many of these drug approvals. So when you're prescribed a therapy for myeloma, you're also going to have the supportive therapy, bone strengtheners, immune fighting therapies, and these are all aimed to optimize your treatment. So there are a lot of different colors of wheel treatment options. I would like to say, my son likes to say, back in my day, we had alkylating agents. That's melphalan, cyclophosphamide, still very important to be used these days, but now we have all these different colors of the wheel, like the mides, the steroids, the bispecific antibodies, and cellular therapies you're going to be hearing about. One of the most important and powerful ways we can control myeloma that we've been doing since the 1990s has been stem cell transplant. So I'm not going to spend too much time on transplant here, but the take-home point is that stem cell transplant is still considered a standard of care among patients that are quote-unquote eligible, meaning you have myeloma as a diagnosis, you're fit, not necessarily frail, and you want to have a transplant. Dr. Williams is a transplanter, but he doesn't offer transplant to just everybody that walks through the door. It's a discussion about the risks, benefits, and alternatives. When you do get selected for that transplant, though, we give you 1 to 4 months of treatment to get you in remission. Then you harvest your stem cells, we put them in the freezer, and then we reinfuse them after a high dose of melphalan or a similar drug combination. You're typically about 3 to 4 weeks, you're in the hospital or in an outpatient by the hospital, and then you have this post-transplant recovery period. We do have a similar process, but that's different, and that's CAR T cell therapy. We still are harvesting cells, but now these are T cells, and I won't go into great detail about this process because you're going to hear about this later, but the take-home point is that this is a long process. So once you are a candidate for therapy, you meet with a cellular therapy specialist like Dr. Williams. He's going to discuss the process. We're going to screen you with labs, harvesting your T cells, shipping them off for about 4, 6, or 8 weeks to be engineered to be fighters, circulating in your bloodstream, and it's like a living drug. You're going to have those accepted back into your blood after a treatment called lymphodepletion, which allows you to not attack those new cells you're getting back. And then there's monitoring. So it's considered a one and done, but maybe more of a one and then some, because then we want to give you supportive therapies like immune protective therapies, as well as bone strengthening. And there's a lot more of that cytokine release syndrome and such that we'll talk about in just a moment. There are not everybody is a candidate for CAR T cell therapy. Again, it's a long manufacturing process. You have to be a candidate. It is approved by the FDA after 1 or 2 prior therapies. So if you had that transplant, then you might be considered a candidate for CAR T cell therapy. But there's also drugs out there. A class of drugs that we use is called bispecific antibodies. Now we have 2 that are FDA approved against a target called BCMA, B cell maturation antigen. This is expressed on healthy cells as well as the myeloma cells, but more so myeloma cells. So you don't have a lot of innocent bystanders, although myeloma cells are programmed to protect you from getting sick. So when we're attacking the BCMA consistently, that puts one at risk for increased infections. There are short-term and long-term side effects of these drugs. The short-term side effect that we worry about from the first week to 10 days to 14 days especially is called cytokine release syndrome. And that's where we're training your, we have the myeloma cell and the T cell, like a helping hand, brings the cells together with the CD3 and causes an explosion of these chemicals called cytokines. You can get a high fever, you can have some shortness of breath, maybe needing some oxygen, but we know how to mitigate this side effect. We know how to treat the side effect with a drug called tocilizumab or some corticosteroids called dexamethasone if you have it. We also have a therapy called talquetamab, which is targeted towards this GPRC5D, maybe a little less infection prevention that we have to do, but it's still quite a bit. So again, it's not just the treatment, it's the supportive care with the treatment. So that was just a very brief overview. You're going to hear more about this later on, but let's talk about symptom management, because we can't address symptoms if we don't know you're having them. We've had numerous studies in Europe and the United States and all over the world looking at quality of life, symptom management. Symptoms can impair you physically, psychologically, and financially. Many people accept side effects of treatment because they think they're getting this chemotherapy, and it's accepted part of treatment, but it doesn't have to be. Many physical side effects you might experience depending on your therapy is fatigue, constipation, pain, neuropathy, and these can negatively affect you psychologically, leading to depression, anxiety, and straining your professional and personal relationships. And then let's talk about the financial toxicity. This, as you heard from Dr. Joe, is not an incurable condition for most, but it's highly treatable for most. So that leads to a financial burden, financial toxicity, etc. So talk with your care team. They're here to help you. You can even go on Milo, the chatbot, go on myeloma.org and type in with Milo, say, I'm having trouble paying for my drugs. Do you have any resources? And Milo can actually help. And I think you heard from Dr. Joe, Milo, if you talk to him in Portuguese, he'll talk back to you in Portuguese as well, which is really nice to know. Now, when you talk about immunotherapy, these side effects will affect the physical symptoms, such as that cytokine release syndrome, where you can get a high fever, and it varies on the onset depending on when you get the treatment. Immune cell effector neurotoxicity syndrome, or ICANS, that's where it can occur with the CRS or independent of, and that can also occur during that short-term usually when you're first getting either CAR T-cell therapy or the bispecific antibody therapy, and then of course infection. So these are the top 3 things I worry about when people have immunotherapy. So many of you are not necessarily receiving these therapies, but some of the physical side effects that you see with somebody who's getting this bispecific antibody or CAR T-cell therapy is that cytokine release syndrome. As I mentioned, lots of chemicals, cytokines are exploding, and they can cause these symptoms such as nausea, vomiting, headache, shortness of breath, etc. A fever is the hallmark first symptom of CRS, and that's what you're going to be watched for real closely. For neurotoxicity, that's that ICANS that I mentioned before. Not everybody will get this, not everybody will get CRS, but a majority of patients will. And so we want to look for things such as, are you able to count back from 100 by 10s? Are you able to do a handwriting sample and be consistent on that handwriting sample? It starts as mild confusion, headache, but it can progress to hallucinations. Again, it's a rare but serious side effect of CAR T, and it can happen in small percentages with the bispecific antibodies as well. Now, infections is the #1 cause of death in patients with multiple myeloma, unfortunately, still. It's not always disease that gets you, it's the infection. So if your provider is recommending antibiotics, antiviral therapy, intravenous immunoglobulin, those are very important strategies to lessen your chance of getting these serious and rare wacky side effects that you can experience. Years ago, we never saw opportunistic infections such as pneumocystis pneumonia. That's what you saw in people that had HIV. Now we recommend regular antibiotics or inhaled things called pentamidine for some people with allergies to sulfa to prevent you from having that side effect. So good personal hygiene, try not to break the skin barrier, environmental control such as avoiding crowds. You know, if you want to go out to dinner, try to avoid the hot time to go out to dinner, go in the early bird special. Make sure you talk to your healthcare provider about immunizations such as the inactivated influenza, COVID, RSV, and pneumococcal vaccinations. And also we're going to have some preventative supportive care. Now, this is a table. We have lots of supportive care guidelines. There was just some CAR T-cell infection prevention guidelines that were updated by the International Myeloma Working Group last month. I believe Dr. Lynn is the lead author of that. I'm pretty sure Dr. Mikhael is an author. If not, he better be. Anyhow, medications can reduce your infection risk. And as I mentioned, there's antiviral. So that's the shingles, cytomegalovirus. One of the things we're screening for is hepatitis B. Now, if you get a hepatitis B test and you see this core antibody positive, we sometimes recommend a pill called entecavir to minimize your risk, and that can be expensive. So don't just not take that medication because it's too expensive. Make sure you have that discussion with your healthcare team, and we'll try to get that available to you. The levofloxacin, if you have really low blood counts like that neutropenia. PJP is that opportunistic infection I talk about that we used to only see in people with HIV. We give pills or inhaled this pentamidine. Some people give IV pentamidine. Fungal infections can occur, so we give you mouthwashes such as nystatin, sometimes pills called fluconazole. We recommend influenza vaccines. Intravenous immunoglobulin can be given if your IgG level less than 400, but some centers will give it regardless if you've been on CAR T-cell therapy, if you can get it reimbursed. We always have trouble with insurances depending on where you live. And then sometimes if you're neutropenic and your absolute neutrophil count is less than 1,000, we give you shots called GCSF. If you're on a medication called talquetamab is that GPRC5D bispecific antibody, you can have some specific side effects. It's expressed on skin cells and oral mucosa keratinized cells. And so unfortunately, you might get dry mouth, taste changes. You have to make sure to get good dental care. We sometimes see swallowing problems as well, and it can cause some weight loss. So I have listed on the slide here. Remember, you can get all these slides for download, but talk with your healthcare provider. We give lots of preventative medications, but oftentimes if you're responding to the treatment after 3, 4, or 6 months, your physician or healthcare team might decrease the frequency of the dose, which can help. Many of the medications we give can cause GI symptoms such as diarrhea or constipation. Talk to your healthcare provider. I have some suggestions on the slide for each of these side effects. If you're on Revlimid long-term, for example, that can cause some diarrhea. So we want to recommend that you talk with your healthcare provider. Cholestyramine is a powder that you can self-regulate. Imodium, also after your loose bowel movements. Look at your supplements. I've had patients that take magnesium in their supplements, and magnesium in high doses that might be hidden in your supplements can cause diarrhea. So really look at what you're taking. Increasing fiber in your diet as well is super important. Getting back to that skin and nail changes, these are specific on this slide to that talquetamab toxicity. You can get skin rashes as well as nail changes. I like to recommend putting nail polish or nail strengtheners on your nails. Sometimes people will come in and they'll have Band-Aids wrapped around their nails because it catches on their skin, but once it falls off, it doesn't necessarily come back. You can also have sloughing of the skin as well on your hands and feet syndrome. Usually aggressive lotioning can help, as well as topical steroids for rashes. Steroids, those of you who are here probably know about it. And back in the day, when we gave thalidomide to treat newly diagnosed myeloma, we also gave steroids 360 milligrams a month, days 1 through 4, 9 through 12, 17 through 20, lots of high blood sugars, mood swings as well. So talk to your healthcare provider about the right time of day to take those medications. You can get some stomach discomfort, so some stomach pills like Prilosec or Pepcid might work for you. And also talking with your healthcare provider about decreasing the dose based on the side effects. A low dose is better than no dose. And I always tell the story about Mike Katz, who was a patient, and he told Dr. Raj Kumar, now he's with the IMF and Mayo Clinic, about his side effects. And he says, why can't we test lower doses of steroids? And he was critical in getting the approval of the weekly dexamethasone, a patient talking to his doctor about side effects, and they work together to find a solution. In terms of pain management, we can't know if you're having pain unless you talk with us about it. Most centers will have supportive care or palliative teams that can help out. We can give you strategies about bone disease, get you at the spine center, and get you with the proper team to help identify and treat your pain. We can give some adjunctive medications as well as pain medications in some situations, although we're very restricted these days in which pain medications we can prescribe in most states. Peripheral neuropathy, that's numbness and tingling for some. The nerves innervate in your spine and they go out into your skin organ and cause some sensory changes. It can affect your motor, your muscles, and cause some motor walking changes. So talk with your doctor about what kind of side effects or symptoms you're experiencing, and we can target our treatment. Sometimes if you're on bortezomib or Velcade, we want to hold or reduce the dose, massaging the area if you're having some numbness and tingling, looking for a safe environment as well, moving away with the throw rugs, as well as furnishing and wearing well shoes. Understanding kidney function is important. Myeloma attacks the kidneys. These high light chain burden, the proteins can be very toxic to the kidneys. So avoid non-steroidal anti-inflammatories. Make sure to stay well hydrated. If you're having high blood pressure from some of the medications, such as carfilzomib that you might be on, that can stress out your kidneys. So working with your primary care provider and your healthcare team is super important. This is a list of some of the supportive care options that we might be considering for you. Multiple myeloma has sticky proteins, and there's lots of blood clotting substances in your blood. So you are at an increased risk of blood clots because not only do you feel tired and in pain, so you're not moving around as much, but also the medications that we're giving you. So you're probably going to be recommended on blood thinners such as aspirin or what we call DOACs, the direct oral anticoagulants, or warfarin if your kidneys aren't functioning normally. For bone health, we give you bone strengthening agents, sometimes recommending vitamin D, and radiation if you have some identified lesions. For fatigue, we have stimulants. I like to recommend Wisconsin ginseng. There have been some studies in chemotherapy-induced fatigue, and there are some people that really benefit from that, as well as increased physical activity. And then finally, anxiety, definitely stress reduction, therapy. These are also important to you. And we have lots of living wells to refer to. And I'm getting towards the end of the deck, and I just wanted to end the last few slides with the rest and relaxation can really contribute to good health. So try to get good, adequate sleep, eat a healthy diet, moderate, I was going to say moderate alcohol. Don't drink too much, it'll affect your sleep. alcohol in moderation, and try to avoid daytime napping. We talked already about financial burden. I did a nice living well about a year and a half ago with my social worker and financial coordinator. There's lots of resources out there, but we don't know if you're struggling with your medical costs or prescription costs unless you tell us. I had a patient the other day that was paying over $500 a month for Revlimid. They just accepted that as the cost of care. She qualified for free medication and reimbursement, so she has zero copay now. I would have had no idea if she didn't bring it up to me. There's federal and local programs as well as NeedyMeds.com, HealthWell Foundation, and others. Again, talk about your care team. Find out who's the people in your neighborhood. Myeloma specialists, those pictures should be Joe Mikhael or Lou Williams up there, not Dr. Dury, although I love him to pieces. He's not on this call, they are. We also have general oncologists, primary care providers who are all members of the team. I'm a nurse practitioner, I'm not a physician, but I help to support my team well. We don't need to talk about telemedicine visits because you should be really good at this now. I love telemedicine though, so we'll talk about that another day. And I think we're about that. There's a care team collage again. We're going to go through this again. Care partners. If you don't have a care partner, try to find one. There's my friend Teresa Mazzelli in the corner with the dog on her head. That talks about the healthy relationships behaviors. Stop smoking, don't start smoking. Care network is really important as well. And the fact that you came here tonight to listen about this is really super important. We have lots of great resources in many different languages. We have, as you heard, Milo can talk to you in Spanish, Portuguese, or whatever language, Mandarin, I think, as well. And we have lots of learning series also. Don't forget, you're not alone. Put questions in the chat. I know that was super quick, but I appreciate you all. And I'm going to turn it back to our moderator, Dr. Joe. Thank you very much.
Well, thank you, Beth. I only wish you had more energy, Beth. You know, it just sort of such a flat presentation, but I know there's a lot of material for our audience to take in. You know, that this presentation is a little slide heavy for the first half, but that's partly purposeful because there's so many aspects to those slides that can benefit everybody. And thank you so much, Beth, for presenting it so well. We already have about 25 questions in the chat. Some of them are going to be pretty challenging, and so I'm very grateful for everybody doing that today. Before we dive into a more detailed Q&A, though, I think we'll go right into Dr. Williams' talk. He's going to talk to us a little bit about frontline therapy, and that way we'll be able to have a more dedicated period of Q&A before we take our break. So Lou, we're so thankful for all that you do for your community, both at the main hub and in your peripheral community clinic that you do. We're so thankful for you and for joining us tonight. We'll let you talk to us a bit about frontline therapy.
Thanks very much, Joe. It's great to be here with Dr. Feynman and Dr. Mikhael, and to look at that presentation. It really reminds me how far we've come in myeloma. I mean, it's incredible. And I've been lurking on that question feed. Those are some good questions. There are definitely some educated people out there tonight, so I hope we can get to some of them. But I'm going to talk about frontline therapy, and this is going to be relatively data heavy. So we're going to try to go through it in a way that's concise. It also hits the high points. Happy to answer questions at the end. Yep, good. My clicker works. So here are our objectives. We want to quickly review the importance of depth of response in early treatment. We also want to talk about transplant eligible patients, what's new in terms of quad therapy and stem cell transplantation with some of the data there. And finally, touch briefly at the end on transplant ineligible patients and how we're approaching that. And we'll also look at some of the new data sets there. So, you know, I think many people have seen this kind of a slide before. And this is here to illustrate the notion that even with, up until recently, our best methods of monitoring treatment response, you know, we talked about complete remissions, we really were limited in our ability to detect, you know, myeloma cells below a certain threshold. You know, maybe 1 cell in 1,000 is kind of what we, broadly speaking, what we were able to detect until very recently. However, we've developed new methods, both through something called flow cytometry and something called next generation sequencing to detect even smaller amounts of myeloma cells that are left over after treatment. We call this minimal or measurable residual disease. You'll see both terms. They mean the same thing. These two technologies, flow cytometry and next generation sequencing, we can get into in the Q&A if you want, but one thing to take away is that they're much more sensitive than what we've had at our disposal. So when we look at these data, we're talking about maybe one myeloma cell in 100,000 or one myeloma cell in 1,000,000. So it's orders of magnitude, a lot more sensitive than what we had at our disposal in the past. And this allows us to assess treatment in a different way and to understand prognosis in much more finely, in a much more detailed fashion. So you'll see that terminology as we go forward. Oh, not sure if sorry, I might need a next slide. Oh, sorry, things are popping up on this slide. Let's go to the next slide. Yeah, so our goal, that illustration was to show that what we want to get rid of as many myeloma cells as possible. And when we're talking about depth of treatment and the overall upfront treatment paradigm, I'm going to take a second to say that, most of the time what we're doing is we're dividing multiple myeloma treatment into really three parts. We're dividing it into induction, which is the treatment you get right when you're diagnosed. And that's usually 4 to 6 months of treatment, depending upon the situation. After induction comes consolidation, and that's about 3 months of treatment. And that's where we'll get to talking about transplant for certain patients. And after that comes maintenance. I just want to make sure everyone on the call has heard those terms. The purpose of induction, what we want to do with induction, which we're going to talk about, we're talking about in this part of the talk, induction and consolidation together. But the purpose of induction is really to get rid of as many myeloma cells as possible in order to spare the organs. So you heard Dr. Mikhael talking about anemia, about bone disease, about kidney disease. Our goal up front is to save the life of the patient, and it's to minimize these organ complications. And we know we do that better the deeper the response we can achieve. And then the purpose of consolidation afterward, when we get to transplant, is really to eliminate whatever's left over after that and set ourselves up for a long-term durable remission. And that's what this slide is essentially illustrating. So we were talking about measurable residual disease and its impact on prognosis. These curves, and we're going to see a lot of these, and I'm happy to go back during the Q&A and look at some of them if you want, but these curves are from a pooled analysis of studies that took place, in the early 2000s. And the treatment that patients were getting wasn't necessarily the same, but these were from 3 different clinical trials that were, with sort of all the patients pooled together in a meta-analysis, where we looked at, or the investigators looked at, the impact on progression-free survival and overall survival of achieving different depths of response. So you can see PR, that stands for partial response. Near complete response is what we call, it's very close to what we call a very good partial response. Complete remission and MRD negative complete remission. And what you can see both on the left and on the right, and this is a single measurable residual disease assessment at 9 months after initiation of therapy. What you can see is actually quite interesting. Complete remission wasn't that important. That's kind of the black line. I don't know if you can see my mouse now, but that's kind of the black line here. And you can see all these lines on top of each other. That shows that there's not much difference between people achieving those levels of, or those depths of response, right? Complete remission is kind of stuck in there with the rest. But if you achieved a complete remission without measurable residual disease, suddenly you see this nice progression-free survival curve, a longer progression-free survival on the numbers at the bottom. And you see the similar trend in overall survival. So even with very early data, and this was not with the modern MRD techniques that we use now, even with very early data, we were able to see that there is something important about reaching this depth of response. So how do we approach frontline therapy? Well, like Dr. Mikhael mentioned, we're still thinking in terms of transplant eligible and transplant ineligible. And ASCT stands for autologous stem cell transplant there, in case people haven't seen that terminology. I think maybe we may move away from this at some point in the future. Maybe the paradigm will be a little bit different, but for now, this is how we're thinking about it. How do we decide if someone is eligible for a transplant for their consolidation? There are a lot of different factors that go into it. There are some scoring systems like the HCTCI that you see there. There is age, although age is never an absolute, in my opinion, should never be an absolute contraindication to this kind of consolidation therapy. And the big one here for me, the big two here really are performance status and comorbidities. And I'll talk a little bit more about that, but I wanted to just illustrate with this slide that there are still two parallel pathways that we're thinking about as we decide, and this is after induction, as we decide who goes to which consolidation. So what are we thinking about in terms of our general principles of initial treatment choice? Well, we're going to be using combination therapies, which we'll talk about. This point number two, that we don't save the best for last, I think is an important one. There used to be some thought in myeloma that maybe, we should not use combinations, or we should not use our best treatments up front and instead save them for down the road. You didn't want to waste treatments. There are a lot of reasons why we don't do this, but one is very practical. We know that in the real world, we lose many patients to follow-up after the first line of therapy. So 30% of myeloma patients don't necessarily make it to their second line therapy, not because the disease prevents them from doing that, but because there are real-life complications and factors that can happen. So I'm a big believer in using the best upfront therapy that we have at our disposal when we can use it. We seek a deep and durable response. We'll talk about that in a moment. I wanted to introduce the three major classes of drugs that we'll be talking about in a lot of these studies. Many people from the questions I'm seeing probably know about these, but proteasome inhibitors are drugs that essentially, you can think of these myeloma cells as protein factories, and they need a lot of machinery on that assembly line. Otherwise, they'll accumulate misfolded proteins, the byproducts of all this protein production, and that will kill the cell. Well, but the proteasome inhibitors, you can think of it as sort of, they block that assembly line. They gum up a part of that assembly line, essentially. And the nice thing about these drugs is that they're very selective for cells that produce a lot of protein. And the myeloma cells in a patient's body are the highest protein producing cells, essentially, in the body. So there's a preferential effect. Immunomodulatory drugs like lenalidomide work, they alter the growth program of the myeloma cells. They also, in a way, activate our own immune systems against them. And the monoclonal antibodies are targeted precision therapies that find essentially a protein on the surface of the myeloma cell and teach our immune system to eliminate the myeloma cells. These chemotherapies are not like chemotherapy for other cancers. The side effect profiles are different, and we can discuss that as we go through. And then we decide early on whether or not someone will have a stem cell transplant. We'll talk about that in a moment. So why do we do this? So why do we sort of use these particular combinations with stem cell transplant? Well, this study is a really important one. This is called the determination trial. And up until very recently, this was this reflected our best standard of care and how to manage patients who we thought were in good enough condition to receive a stem cell transplant up front, who were in good shape, essentially. And this study involved taking RVD, which is an abbreviation for Revlimid, Velcade, and dexamethasone, or lenalidomide, bortezomib, and dexamethasone. I might use the generics because that's how I train myself to, so forgive me if I say that. Followed by stem cell transplant versus RVD without stem cell transplantation. And you can see the paradigm there. So these are patients, this is about 700 patients. They were randomized to receive, after everybody got 3 cycles of induction, they were randomized, and stem cell collection, they were randomized to either receive high dose melphalan, which is a plus stem cell support, that's an autologous stem cell transplantation, and then go on to receive 2 additional cycles of consolidation, or just to go ahead with 8 straight cycles of RVD, and then everybody went on to maintenance therapy afterward. So this trial was asking the question, and if any of my patients are on the call, they probably have heard me discuss this in one of our visits. This patient was asking the question, this trial was asking the question about the role of stem cell transplantation in our management. So everyone got the same induction, consolidation is what was different. And so what did we find in this trial? Sorry, here, I should have mentioned that the primary endpoint was progression-free survival, and there were some important secondary endpoints. The follow-up of this trial, the median follow-up is about 76 months at the moment. And so, that was slow. But anyway, sorry, what did we find with the primary endpoint, which is progression-free survival? Well, the red line on top are patients who went to transplant, and the blue line on the bottom are patients who didn't go to transplant. And you can tell that the blue line drops off, sort of right after induction. You start to see separation between these curves. And what we found is that on average, patients had a 20-month prolongation of progression-free survival if they went to autologous transplant. So in other words, the time until the disease either came back or a patient unfortunately passed away was 20 months longer in the transplant arm of the trial. Sounds great. Sounds wonderful. So why would anybody choose an alternative? Why would you not want to go to transplant? Well, as time went on, as time went on, as I say, you have your median follow-up of 76 months there. As time went on, we got more and more information about overall survival. And this has to do, this is obviously, it's an endpoint that's exactly what it sounds. It's how long did people live? And at 76 months of follow-up, no difference. You can see those curves are right on top of each other. And this recapitulates, the data we got from another trial called the IFM 2009 trial, which was an earlier version of this same study. So we have a progression-free survival benefit, but no overall survival benefit. When we looked at quality of life was essentially the same between the two arms. With the exception that dip you see there in the red line was when people were in the hospital for their stem cell transplant. So unsurprisingly, people didn't love being in the hospital and getting high-dose chemotherapy. So how do we rationalize these findings? We can talk more about it in the Q&A session, but there are a couple of things to keep in mind. One is that progression-free survival doesn't necessarily always translate into overall survival, especially if we have very good salvage treatment. So we have really good treatment now for multiple myeloma, meaning even if you made it 20 months longer without the disease coming back, even if you were in the group that went 20 months shorter before the disease coming back, we have options to sort of catch you up to the transplant group. And that's what we saw in this trial. So even though those patients progressed sooner, they didn't necessarily, their overall survival wasn't necessarily impaired. Another thing to think about is that about 25% of the patients who weren't supposed to get transplanted in this trial ended up getting it at when their disease came back. So there was some crossover here. There was also less lenalidomide given as maintenance in the transplant arm for reasons we don't need to go into. So this is still a decision that is very individualized. That's the point of this, why we're showing you this. So we have data that you can get prolonged PFS from a transplant. Some patients find that attractive, and other patients say, you know what, I'm not going to live any longer. I'm going to go to the hospital. I'm going to be out of commission for 3 months. Forget about it. So this is still something that's very individualized. I'm going to move on because we have a lot to cover, but we can discuss this in the Q&A a bit more. So we touched on all of these points, but I will say the toxicity is something to mention. So stem cell transplant is very safe overall from a mortality perspective. The mortality is 1% essentially for an autologous stem cell transplant. So there's not much chance of dying from the transplant itself. You have to remember the chemotherapy alone carries some mortality. So it's not a 0% to 1%, but there are all kinds of other toxicities. You feel bad, you lose weight, there's mucositis, you have to be out of work, you're immunocompromised afterwards. So there are, mortality is one side of it, but there's also morbidity. There's potential infections as well. So it's not always a cut and dry decision, even for people who are transplant eligible in the modern era. So you'll notice that the induction regimen for that trial was RVD, and for a long time, that was the standard of care. Now, though, the question has been asked about whether or not we can do better than RVD for induction. And here you see the schema of the Perseus trial, the phase 3 Perseus trial. This trial, and there's a lot of information on this slide. You'll have these, you don't need to kind of memorize it. But what the question this trial was essentially asking is whether or not the addition of daratumumab to that same RVD backbone or VRD backbone improved progression-free survival. One important aspect of this trial, and you can see this was a trial that included transplant. So you can see there's an induction, there's a consolidation, there's a transplant and consolidation together, and then there's maintenance. An important aspect of this trial to consider when you're thinking about it is that daratumumab was added across all phases of treatment in this trial design. So in other words, if you were randomized to receive daratumumab, you received it during induction, during consolidation, and during maintenance. During the maintenance phase, you'll also see that there was an MRD assessment in the daratumumab arm, and people who were MRD negative can discontinue daratumumab. People who were MRD positive continued on both daratumumab and Revlimid together. So that was the overall design of the trial. this is what we saw. So at a median a median follow-up of about 48 months, so about 4 years, you saw a clear separation in the curves in terms of progression-free survival. So 48-month PFS was statistically better with the addition of daratumumab as compared to VRD, the control arm, our standard of care at the time. Likewise, you could see that there was a greater complete remission rate for, as you can see on the left, for the daratumumab and VRD arm. On the right, this is called a forest plot, and these kinds of plots can show us some of the outcomes for various subgroups. Now, you have to be careful because there are small numbers of patients in a lot of these subgroups, and so these are sort of instructive. They shouldn't be taken as sort of the last word on this regimen. However, you can see that most of the patients that seemed to benefit were standard risk patients. So high risk patients, if the forest plot line crosses this dotted line, it shows that there wasn't a definable benefit based on the design of the trial. So high risk patients and patients who had ISS stage 3 disease, as well as elderly patients, the value of daratumumab VRD based on this study is less certain. You can see also that, unsurprisingly, at both MRD levels of 10 to the negative fifth and 10 to the negative sixth, so 1 cell in 100,000 and 1 cell in a million, the quadruplet, the 4 drugs together, achieved higher rates of MRD negativity, and this is throughout the whole trial. Importantly, sustained MRD negativity greater than 12 months was double in the quadruplet arm, and really, we think that the best biomarker is sustained MRD negativity as opposed to a single MRD negativity at a single time point. So I think that's very telling. Thus far, as the trial matures, there's no difference in overall survival. However, we expect this data to mature, and we'll have to see in the future if, a big question coming out of this is, will the quadruplet actually confer an overall survival benefit? Because we saw in the determination study, it's not necessarily, PFS benefit doesn't always translate over to overall survival benefit. And quickly on safety, with almost every trial where you include an anti-CD38 antibody, you'll see greater hematologic toxicity and a slightly higher propensity to infection. But you can see that the numbers for infections for serious infections, grade 3 and grade 4, aren't tremendously different. Most of the neutropenia that was seen with the daratumumab, with the antibody addition, didn't result in neutropenic fever or infection. So that's encouraging. There wasn't in practical use, I'll say, there's not a great deal of toxicity added by using an anti-CD38 antibody that the patient feels. You have to be careful about some infections and prevention strategies and things like that. But in the interest of time, I'm going to move on quickly to just show you the scheme of this trial. There's another anti-CD38 antibody called isatuximab. It binds to CD38 slightly differently. It kills myeloma cells very efficiently with many of the same mechanisms as daratumumab, with a couple of different exceptions that we can talk about maybe in the Q&A if people are interested. You can see the induction phase. This is the trial comparing isatuximab RVD with RVD. So kind of the same idea as the Perseus trial, but with a different anti-CD38 antibody, slightly different duration of maintenance therapy, but overall very similar trial. So this is the setup for the trial, very similar patient population. And what we saw is that the primary endpoint, which was different, it was MRD after induction, MRD negativity at 10 to the negative fifth after induction. And you could see that there was a statistically significant difference between the quadruplet and the triplet. Finally, as we're discussing quadruplet therapy, this is another study. It's called the Ischia study. It was presented a couple of years ago as a big presentation at one of our annual meetings. This is a trial that looks at adding isatuximab to a different backbone. KRD is carfilzomib, Revlimid, and dexamethasone. So it's substituting a different proteasome inhibitor besides bortezomib. So we had VRD before, we have KRD here. And the interesting aspect of this trial is that MRD was checked. You can see at the bottom, MRD was checked at many different time points: after induction, after transplantation, after a first round of consolidation, and then after essentially 12 months of 12 cycles of extended consolidation. One thing to point out here is that these patients in both arms had far longer, far great, a greater intensity of consolidation than did patients in the Perseus trial, just based on the trial design and the amount of treatment they received. So when we look at the primary endpoint for post-consolidation MRD, you can see that the ESA-KRD achieved 77% of patients receiving the quadruplet achieved MRD negativity at that threshold versus 67% with the KRD backbone. And likewise, when you look at, the deeper responses at 10 to the negative sixth, you see a similar separation. And one thing that we see in many of these trials is that both responses and MRD negativity rates will improve with extended duration of treatment. And this is what we see over time. So post-induction, you can see in the ESA-KRD arm, you could see the percentages of patients achieving MRD negativity increase from 45% to 64% to 77%. And that's why we don't often rely on just a single time point when we're looking at the efficacy of these treatments in terms of MRD assessment. Likewise, you can see that in the KRD arm, we saw something similar. Although the absolute levels of MRD negativity were lower, you saw deepening of response over time with additional treatment. An interesting aspect of this study is that the quadruplet in this data set seems to abrogate some of the HRCA there stands for high-risk cytogenetic abnormalities. So when you look at patients who don't have any high-risk cytogenetic abnormalities versus patients who have one high-risk cytogenetic abnormality versus patients who have two high-risk cytogenetic abnormalities, what you usually see in a lot of these trials is that the one high-risk cytogenetic abnormality and the zero high-risk cytogenetic abnormality usually behave close to similarly, depending upon which data set you're looking at. And you usually see a fairly big drop-off in terms of responses and depth of response with the 2+ high-risk cytogenetic abnormalities. Interestingly, when you look at the very high-risk group in both 10 to the negative fifth and 10 to the negative sixth, you didn't see that as much in this trial. In fact, there was more MRD negativity to 10 to the negative sixth in the very high risk group here. So this is something that needs to be looked at a little bit more closely. These subgroup analyses often have small numbers of patients, so it's not necessarily the end all be all, but there's a signal here that this particular quad may abrogate some of that very high risk. So we've talked about a lot of these conclusions. Joe, how am I doing on time?
You're good. I mean, I think we planned somewhere another 5 to 10 minutes. And
okay, sounds good. Sounds good. Okay, so I didn't want to eat into the Q&A too much. Now we have MRD as this great tool that tells us a lot about prognosis, and it tells us a lot about how efficacious our treatments are. A natural question is, right now the paradigm for treating for upfront treatment of myeloma is we treat patients essentially, or at least the clinical trials. The real world is a little bit different, I think, in some cases. But in clinical trials, our clinical trials thus far, up until very recently, were designed to treat patients until disease relapse or intolerance of therapy, and that's a one-size-fits-all strategy that involves a lot of time in the treatment center. It involves a lot of cost. It involves increased risks associated with prolonged consolidation and maintenance, including infection, including venous thromboembolism, other complications, and neuropathy, and rarely people do die from chemotherapy treatment. So there's a lot of interest in looking at MRD as a tool to potentially decide when is the right time to maybe give a treatment-free interval. And so one of my favorite clinical trials published recently is called the MASTER trial. And the MASTER trial was a trial that looked at DARA-KRD. So if you remember, very similar background to the Ischia trial we were just looking at with the KRD backbone, so carfilzomib, Revlimid, dexamethasone. This time it's paired with daratumumab, which is one of the anti-CD38 antibodies that we mentioned before. What was done in this trial that made it unique was that MRD was checked at post-induction, post-transplantation, post-consolidate, and post each block of 4 cycles of consolidation. And if patients were MRD negative at 2 successive time points, they were able to go off of therapy and start a surveillance program. So I just want to be clear, this wasn't, if someone was MRD negative 2 times and they, we said goodbye, don't come back, go relax, you're cured. That's not what we did. But we stopped treatment and we closely monitored their paraprotein labs, their renal function, monitored for evidence of bone disease, essentially monitored for disease recurrence, but they came off of treatment. And what we saw was very, very interesting. So in this trial, it's a progression-free and overall survival. We saw that progression-free survival and overall survival were very similar for patients. By the way, this trial was enriched for patients with high-risk cytogenetic abnormalities. And so almost, I believe, 30% of the patients in the trial actually had 2+ high-risk cytogenetic abnormalities. And what you see is that one high-risk cytogenetic abnormality essentially behaved similarly to patients with 0 high-risk cytogenetic abnormalities. As I mentioned earlier, you can see that big gap in the progression-free survival curves on the left and a less pronounced gap in the progression-free survival curves on the right. And what we're seeing there down at the bottom are the 2-year progression-free survival numbers. Now, what's interesting is we looked in the analysis in this trial at patients who were able to go on to surveillance. So in other words, patients who were able to met the MRD endpoint. And it was about 73% of patients who met this endpoint. Of those patients, and I want to say there were about 84 of them, only 9% of patients who went off of treatment who were in the 0 high-risk cytogenetic abnormality group had disease recrudescence, either through MRD positivity or through actual, serologic progression or symptomatic progression. So especially, and that's with 24 months of follow-up after stopping treatment. So there is a signal here that while patients may not be cured, and the number, by the way, it was about 14% of patients who had 1 high-risk cytogenetic abnormality, and it went way up if you had 2 high-risk cytogenetic abnormalities. So at least for some patients, it looks like there may be a way to use MRD to determine the optimal duration of treatment with very low risk of the disease coming back and harming the patient. So here are some conclusions for frontline therapy in patients who are eligible for transplantation. We are transitioning certainly toward quads. I think maybe you could argue that many of us are already there and using quads as our standard of care. Dr. Mikhael and Dr. Feynman can opine about that. But I certainly have moved in that direction. There is a role for transplant, I believe, especially in high-risk patients. I didn't mention in that determination trial, the PFS difference was 55 months versus 17 months for high-risk patients. Now, that wasn't powered for overall survival in that subgroup, but for high-risk patients especially, I do think there's still a role for autologous transplant in myeloma. Consolidation therapy tends to deepen responses, and it can be considered. So I think consolidation is less popular maybe in the United States than it is in Europe and other places. I know that I don't routinely use it except in very, very high-risk patients where there is residual disease left over after transplantation. I will consider doing a couple cycles of consolidation. And MRD-guided discontinuation is likely possible in lower-risk groups, but not in high-risk or very high-risk patients. And I think that's a good summary of where we're at. If I have 5 minutes, we can talk about, I'm not going to talk about all of this. We touched on this already, and I'm happy to elaborate in the Q&A session. I was hoping, okay, so we have, the general idea here is that transplant eligibility is decided on a patient-by-patient basis. There's some objective information that goes into this, but frailty assessment's a big part of it. Social support is a huge part of it. Patient preference is a big part of it. And, comorbidities, especially cardiovascular comorbidities, are especially important. I'm happy to discuss further our approach to selecting patients for transplant if we have time. I wanted, though, I'm going to go through this and this. I wanted to talk about what we do for patients who are not transplant eligible to make sure that the patients on the call got to see this. So this was a very important trial. This is called the MAIA trial. And what this trial did is it evaluated a triplet therapy that included daratumumab, Revlimid, and dexamethasone versus a doublet therapy, Revlimid and dexamethasone, for patients who were deemed not to be transplant eligible And importantly, it included a high number of patients who had aged greater than 70. And so we got a lens into how this treatment works for patients who are on the older side. You can see the treatment scheme there. It's daratumumab, len-dex, Revlimid, dexamethasone. That's pretty standard. And Revlimid, dexamethasone was a fairly standard approach to transplant-ineligible multiple myeloma. The primary endpoint here was progression-free survival with some secondary endpoints, including overall survival and PFS2, as well as MRD negativity. And here, this is highlighting the baseline characteristics of the patients, and there were a significant number of patients here, 43%, 44% in the two arms of patients who were aged greater than 75, which I think is important. There's also about 15% high risk cytogenetic abnormalities in either arm, but generally we'd consider these well balanced. And what you saw in terms of overall response rate at two successive time points is that the overall response rate was higher and responses were deeper in the daratumumab, Revlimid, dexamethasone arm at both follow-up intervals. But response rate, in my mind, is less important than what we see in terms of progression-free survival. And the 60-month PFS rate here was essentially double in the patients who received the daratumumab backbone. And this trend was held true for the older patients as well in the trial. So this is a pretty significant difference, and it definitely met the threshold of statistical significance. There's also a signal here towards statistically significant overall survival at 60 months. And so there's a clear overall survival, or we can say a statistically significant overall survival benefit to this regimen. And the Maya approach, given the very low toxicity of daratumumab and the low additional toxicity of daratumumab, has become a standard of care in the treatment of transplant-ineligible patients. Last thing I'm going to say is that we're now looking at quadruplets in here for the transplant-ineligible patient population. And these trials to know that will be coming on the horizon are the Cepheus trial, which is looking at daratumumab VRD in transplant-ineligible patients. And two trials to look at out there are the IMROZ and BENEFIT trials as well in the transplant-ineligible population. I think I just about got there. So what we're trying to do in the transplant-ineligible population is to balance efficacy and toxicity. I would say that we're trying to do that really for all patients. Dexamethasone is mentioned here, so I peel back that dexamethasone just about as quickly as I can. After we get patients into a remission, even in the second and third cycle when I'm using the Maya regimen. And VRD, we didn't show this data. There is, I think, a role for VRD in the transplant-ineligible population, although bortezomib-related or Velcade-related neuropathy can be difficult to manage in this transplant-ineligible patient population. On the other hand, some would argue that there's very good data to use twice-weekly bortezomib in kind of an RVD regimen, and that maybe efficacy outcomes are slightly better. These regimens haven't been, like so many things in myeloma, haven't been compared head-to-head, so it's very difficult to draw conclusions there. And I agree with that last bullet point. I think we may get to quads in transplant-ineligible patients, maybe with a timed withdrawal of the Velcade piece of it before too long. So I think with that, I'm almost on time. Oh, there we go, last slide. So this is a lot like the slide that Dr. Mikhael showed at the end of his talk, and it's a little bit of word salad, so this isn't to be memorized, but there are a wealth of options out there, whether you're considered transplant eligible, transplant ineligible. We're going to be looking at things like CAR T cells in the upfront setting. There are randomized clinical trials comparing CAR T cells to transplantation. The bispecific antibodies will also be moving up toward the frontline settings. So the landscape's going to continue to change. One thing that's going to happen is we're not going to be able to do clinical trials fast enough to keep up with all of this. And so there's going to be a lot of really looking at different data sets, comparing. It's a good thing to discuss with the myeloma, with your myeloma doc and the team, and it's a good thing to talk about and any sort of second opinions. There's a lot to parse here, and I have tremendous hope for the future for both patient populations, and I think we're going to see that survival continue to get better and better and better. And that's where I'll leave it.
Sweet. So thank you so much. Fantastic. I'll maybe just add, in addition to all that you've just said, that we did actually, of course, have a recent approval for isatuximab plus VRD for transplant in eligible patients. Sorry, I had a couple more slides there that didn't make it into your deck, my friend, but no worries. And that I think really the dawn of quadruplets are here. That Perseus study that you've shown has now been presented, and I think now we're almost going to get into an era where we're not thinking as much about is someone transplant eligible as much as are they quad eligible. And I agree with you, whether we're using isatuximab with VRD, which is now FDA approved, or potentially daratumab with VRD, using the V becomes really important, meaning I think we can dose it once weekly like they did in the benefit study. So this was a study that compared using isatuximab RD versus isatuximab VRD, and they just gave the bortezomib once weekly, and it was a lot easier on our patients. So if patients are older, more frail, maybe not eligible for transplant, we really have to be careful the dosing of all of those drugs. And as we come to some of these questions now, it's amazing how a lot of them have to do with dosing. And I'll just say that when I give ISA VRD or Dara VRD in an older, more frail patient, we don't really change the dose of the Dara or the ISA, but I give the bortezomib subcutaneously and only once weekly. And often after 6 months, I drop it to every other week even, and then plan to stop it at a year. I don't give 25 milligrams of lenalidomide. Like you said, Lou, in the trials, we kind of have to do it at the most intense regimen. But for most of these patients, I'm giving them 10 milligrams of lenalidomide.
Agreed.
And the soapbox that I'm going to jump onto, that Beth knows for sure, is going to be the down with dex movement that we'll talk about in one of these questions. But, we use much less dexamethasone. I start at 20 milligrams once weekly for those patients who are less fit, and often only give that key dose for the first couple of months and then start a taper. That most of my patients are off dexamethasone between 4 to 6 months. And we know they do just as well. And now with all these combinations, we clearly don't need as much dexamethasone. Well, we have time now to answer some of these questions. We had planned a break in about 5 minutes from now. I think we'll do the break in about 10 minutes from now. But we're going to start this rapid fire Q&A. We already have over 30 questions asked, so this is fantastic. And so let's just zip through them, and I may lean to both of you to help answer the question. This first question is, I have multiple myeloma, but the 17p chromosome damage or 17p deletion, I am on Pomalyst. It's kept me in remission for close to 4 years. What are the challenges going forward? What is the expectation of Pomalyst to no longer work? I mean, I'll just quickly answer and say, first of all, I'm very thankful that you shared that with us. I'm very thankful that you've gone 4 years on pomalidomide, especially with the 17p deletion. That may not always be the norm. One of the things that I think we always want to mention in myeloma is that high-risk status isn't necessarily a death sentence. Just because someone may have that, it doesn't mean they can't do well with treatment. I think the expectation is at some point, unfortunately, the disease will break through that pomalidomide, but there are so many other choices, as we've heard today, and we trust that will go well. A quick question here was, isn't active myeloma when clonal plasma cells are greater than 60%, not 10%? And thanks, Gerald, for that question. Let me just clarify. For someone to have active myeloma, they have to have more than 10% and one of those defining phenomena, like one of the Crab criteria, so calcium elevation, renal insufficiency, anemia, bone disease, or one of the other 3 defining criteria, which is the plasma cells greater than 60%, the light chain ratio greater than 100, and the MRI finding more than one focal lesion. So you don't need over 60 to have active myeloma. Someone can have 12% plasma cells and anemia, 12% plasma cells and renal insufficiency. But if you just have over 60% plasma cells and none of the other criteria, we still consider that active because we know there's so much burden of disease that it is likely going to grow very quickly. Beth, let me ask you this question. Does myeloma affect the rate at which bone fractures heal?
Ooh, that's a great question. So if you think of the bone environment, so we have these cells called osteoblasts that their job is to build bone and remodel bone. Osteoclasts nibble away at the bone. That balance in our bodies is affected by the myeloma cells. So if your myeloma is active, you don't have good control of the disease, then you're more likely to get fractures and weakened bone structure. That's why we get these drugs called zoledronic acid or Zometa. Some people get pamidronic acid, or the third one is called denosumab. That's a shot that's given monthly. So anyhow, it doesn't matter. We have a lot of questions. Long story short, yes, active myeloma can impair the healing of the bones. Also, if you've gotten too many of these bone builders over time, you can get this weird cancellous bone malformation, and so that can cause a problem too. So if you have disease that's in good control, though, it should be okay, though. And in my opinion, in working with bone disease, I don't know if Dr. Joe or Dr. Lou, if you agree with that, but if you're well controlled with your myeloma, then you should have pretty good bone remodeling.
Agreed.
We let patients go and have hip surgeries and knee arthroplasties if they're in remission. So once the disease is in remission, bone healing should return to close to what we think is physiologic normal.
Absolutely. Beautifully said. Here's a question someone's asking about. Thank you, Doug, for this question, asking about smoldering myeloma. From a myeloma perspective, is there a risk in actively treating smoldering myeloma? So the decision was made to treat smoldering. Is that going to burn bridges down the line? Lou, what's your quick sense about that? I know that's a complicated area we didn't spend a lot of time on.
First of all, this is a great question. And this is a rare reason to treat smoldering, but if you have an inhibitor, that's one of the reasons why we would do that. There is data from some of the early trials in treating smoldering. There was a big fear about using up therapies, or would relapses be more aggressive? But actually, in some of the older trials, the use of treatment to treat smoldering didn't affect second progression-free survival in those studies. And so it indicates that you're probably not burning bridges. Now, this is a unique, using a bispecific upfront like this. I'm not sure that we know whether, those trials were with Rev and Dex, not with modern sort of T-cell redirecting therapies. But with that caveat, I would say that there's probably little danger in terms of burning bridges, and you need the treatment anyway. One thing we worry about in treating smoldering is infection and making sure that we don't expose patients to excess toxicity. And so it depends on what risk you're talking about. Certainly you have to be careful about infection, but I don't think there's a risk of creating a more aggressive creating myeloma that progresses symptomatically in the traditional sense through doing that. Yeah, go ahead.
Beth, go ahead.
Susan. So this is why we recommend generally to treat smoldering myeloma in the context of a well-designed clinical trial, because we still don't know the right answer. Like Dr. Lou said, there are some good studies that support early treatment and getting you back to that MGUS state, but then there are also an unknown with that. And we have greater drugs now, like bispecific antibodies, CAR T-cell therapies for smoldering trials. So if you have smoldering myeloma, talk to Myelo and ask them where there's a center around you for clinical trials.
Yeah, I think that's really important. I think the reality is we don't know, right? And we're still learning. We're going to see clinical trials in a few weeks that are treating smoldering myeloma, and we don't want to overtreat or undertreat. We know we shouldn't treat MGUS. We know we should treat myeloma, but that in-between phase, we're still sorting out. All right, let's pick up the pace here. A couple of quick questions. Steve Weinstein, thank you, Steve. Always great questions. Does the number of extra copies of 1Q make a difference? Yes, it does. When there are 4 or more copies, what we call the amplification of 1Q, we know that's high risk. When there are just 1 extra copy, meaning 3 in total, because we all should have 2, it's a little bit gray. I would say that it's probably intermediate risk, meaning that it does confer a bit of a high. I had a discussion with the patient clinic today who had this, and we don't know the answer fully. We'll learn that a little bit more with time. How long should post-transplant stay on lenalidomide if remission is maintained? Dr. Williams is going to be talking about maintenance therapy, so maybe we'll defer part of that question for a bit later, but maybe you can answer that in your talk, Lou, and also whether or not 5 or 10 milligrams is sufficient in terms of the dosing of lenalidomide. Kim Swanson asks, is high-dose chemo required for CAR T to kill myeloma before transplanting the T cells back? Would CAR T ever be used as an alternative to stem cell transplant? So very quickly here, Kim, we don't give full-blown chemo before we give T cells back. We sort of give moderate dose, and the concept of that chemo is not about touching a patient's myeloma, but is calming their immune system, because they're going to get all these hyped up Rambo-like T cells that have been supercharged to take down myeloma into their system. And so we give them what's called lymphodepleting chemo, or that chemotherapy that just calms the immune system. And your second question, which is brilliant, would CAR T ever be used as an alternative to stem cell transplant? We're doing those clinical trials right now, so we don't have the answer yet, but we are testing that. Maybe for Lou, do all bone marrow biopsies include MRD negative testing?
That depends upon where you're doing them. No, not as a routine matter of care. It's usually something that your doctor has to order separately, but it's not a hard test to do. It doesn't involve anything additional, to the bone marrow biopsy. It's simply having the right setup to do them.
Okay. Well, we're almost done with time, but I'll take this last question, then we're going to take a little bit of a break. The question is, can you talk a little bit about linvoseltamab? So when we talk about relapse disease, we'll talk a bit more about all the MABs, the bispecific antibodies. We have 3 that are currently approved: teclistamab, talquetamab, and elranatamab. But there is one that at any moment we may hear about it. There was a little bit of a delay in its approval, but we're very excited about this as well, called linvoseltamab, or Linvo for short, as we call it. And this is yet another bispecific antibody that grabs onto the BCMA part of the myeloma cell and grabs onto a local T cell, engages that T cell, activates it. And we're excited about this drug. It looks like it's also very effective. It may have a lower rate of some of the side effects that we see with these drugs, namely the cytokine release syndrome. And that is, I'm going to predict, likely going to be the next drug approved in multiple myeloma. So with that, let's take a quick 10-minute break. It's 10 after the hour now, and we'll be back at 20 after the hour. I always say it's professionally embarrassing if you get a DVT during an IMF talk, so everybody get up, walk around, have something to drink, and we will try to get to, because we'll have more Q&A time after, we'll try to get to the rest of the 38 questions after the next set of talks, which are a little lighter than the ones we've had. So thanks, everybody. Let's take a quick break. Welcome back, everybody. I hope you had a nice little break and maybe got a little something to drink and powered up for this last hour and 10 minutes where we have two shorter talks now and a lot more time for Q&A. So we'll be able to do that. Just want to give another shout out to our sponsors. We're very grateful for your contribution to help us make this happen. So we have heard from Frontline Therapy, and now Lou is going to take us into maintenance. So, Sir Lou, I shall turn it to you.
Thank you. All right, so we're back, and we're going to talk about sort of the third piece of our myeloma roadmap, which is what you do after you get through the frontline or the initial induction and the consolidation, whether that's a transplant or more chemotherapy. We're going to discuss the principles of consolidation and its application. We'll talk about the major options for maintenance therapy. We'll introduce the idea, the concept of dual maintenance, and we'll provide an algorithm for maintenance based on risk status. So this is a little bit of what I mentioned earlier, and it's actually laid out quite nicely here in this slide. So induction and consolidation generally, in transplant eligible patients, what we're talking about is 4 drugs given, generally for anywhere between 3 to 6 cycles to achieve a rapid remission. Consolidation, at least at this point for the transplant eligible folks, is generally autologous stem cell transplantation. After that, after we've achieved our goal of firstly saving the organs through a rapid, through a good induction, and then getting rid of the resistant fastidious myeloma cells that are left over through consolidation, our goal with maintenance is to treat the patient less intensely for a longer period of time in order to sustain that hopefully very deep remission. And so you see down here, what we're trying to do is we're trying to deepen remission and prolong remission, but also really working on minimizing toxicity in this phase of treatment. We really want patients to get back to living their lives, and to have myeloma. If we can't eliminate myeloma from the picture entirely, we want it to fade into the background during this phase of treatment. So our standard of care for maintenance right now at this moment in general is Revlimid, lenalidomide. It's generally given, I give it most often days 1 through 21 of a 28-day cycle at a dose of 10 to 15 milligrams. In some clinical trials, you'll see it given for the whole 28-day cycle without a break. Find that very challenging for most patients eventually. There are a number of clinical trials that are relevant to the maintenance setting, including the 3 that you see down there, the IFM 2005, the CALBG 110104 trial, and I believe that last one is the Myeloma 11 trial. And so these 3 trials were all a little bit different. And this is what we run into a lot in multiple myeloma. So people did use different kinds of inductions and did maintenance for different periods of time in these trials. If you look in this meta-analysis, so this is, again, another study where all of the patients from these trials who went on to transplant and then received either lenalidomide maintenance or no maintenance were all pooled together to see if we could detect differences in overall survival. The median time on maintenance in this trial was 28 months. But the times that maintenance was given, the duration of maintenance was very different between the 3 trials. So keep that in mind as we look at the data. And you can see that we're only including in this meta-analysis patients who went on to transplant and then either received lenalidomide and placebo. So this is a slide that we can come back to the schema if people want to have a look at it. But I want to get to the overall message here. And here we go. So these were 3 randomized trials, and there were about 600 patients in either who did or didn't get maintenance. The median follow-up was about 6.5 years, and the progression-free survival was about 52.8 months for those who received len versus 23 months in the placebo arm. The PFS2 was also prolonged, interestingly, for patients who did get len versus didn't. The median OS in the initial readout was not reached versus 86 months. I believe there was a later readout where the median OS was around 111 months in the len receiving patients in this meta-analysis. But regardless, there was a steep difference here that was statistically significant in overall survival. And there were patients who benefited regardless of their depth of response following induction and transplantation. It's worth mentioning that 29% of patients discontinued lenalidomide. It's not always an easy drug to take over a long period of time. And very importantly, the second primary malignancy rate was higher with lenalidomide. But I think as we'll see, I'm going to go to the next slide here. Oh, that slide wasn't included. What we'll see is that the risk of dying from multiple myeloma outweighed the risk of passing away from one of the second primary malignancies. This other trial we're looking at is the Myeloma 11 trial. This is a really interesting trial where people were randomized, or patients were randomized at 3 different phases: induction, intensification, and then also at the maintenance phase. But there was a randomization to lenalidomide versus observation, and the lenalidomide dose here was 10 milligrams daily, days 1 through 21 of a 28-day cycle. And this trial included both transplant eligible patients and transplant not eligible patients. And if people are wondering, the induction that was used in this trial was cyclophosphamide, thalidomide dex, cyclophosphamide, Revlimid dex, and there was an arm that had carfilzomib, Revlimid, cyclophosphamide, and dexamethasone. So not quite what we're doing nowadays. When you looked at patients who were receiving lenalidomide as maintenance versus those who didn't, the median progression-free survival was 36 months versus 18 months in the observation arm, and this reached a level of statistical significance. And once again, you can see that there's a pretty distinct separation here in these progression-free survival curves. When you looked at a meta-analysis including all the 4 trials that we mentioned, so the 3 trials that were included in the first meta-analysis and the Myeloma 11 trial, there's a clear benefit. The hazard ratio for progression-free survival is 0.47, and you can tell none of these lines here cross 1. And there's an overall very, very distinct progression-free survival benefit. When you look at overall survival, the overall survival also, favored lenalidomide. What's interesting is that you see 2 studies here, the IFM and this Italian study, the Gemima study. You can see that they actually both cross the threshold, whereas the CALGB trial did not. The CALGB trial actually was the only of the 3 trials independently to demonstrate overall survival benefit. That simply means that there's some heterogeneity in the data, but when you pull all of it together along with the Myeloma 11 trial, and those are the Myeloma 11 patients who underwent transplant, you do see an overall survival benefit for lenalidomide-based maintenance as opposed to observation. Can we do better than lenalidomide alone is a very important question. And one trial that addresses this in an elegant way is called the Forte trial. The Forte trial is a trial that was conducted comparing essentially 3 regimens. You had an arm of the trial that received KRD, so carfilzomib, Revlimid, and dexamethasone, 4 cycles, went on to transplant, and then received 8 additional cycles 4 cycles of KRD afterward as consolidation. You then had an arm that was also a transplant arm that had carfilzomib, cyclophosphamide, and dexamethasone, so a different induction regimen, went on to autologous transplant, and then underwent consolidation. And then you had an arm where no transplant was conducted, so you had 12 total cycles of KRD. There was a first randomization to one of these arms, and then a second randomization where patients were stratified based on which arm they had been part of initially to either lenalidomide or carfilzomib and lenalidomide maintenance. So there were 2 randomizations in this trial. The initial primary endpoint was depth of response after consolidation, and then it's progression-free survival for after the second randomization. And so what did you see? Well, what did we find? We found that the KRD arm where patients were transplanted and then underwent consolidation at about 4 years of follow-up outperformed both of the other two arms, the KRD 12 arm and the KCD with autologous stem cell transplant arm. And that's the graph you see, the Kaplan-Meier curves you see on the left. Interestingly, transplant with KCD induction was no better than KRD induction alone without transplantation. So that's something interesting from this trial. On the right, you can see Kaplan-Meier curves reflecting PFS and comparing KR versus R. And there was, at the last readout of the trial at 37 months, a statistically significant benefit to receiving 2 agents in therapy versus 1. So for the carfilzomib Revlimid arm and versus the Revlimid arm. And this held true actually across patients with both standard risk and higher cytogenetic risk disease. And actually here you see it in this next slide. So you can see that for the standard risk and the high risk patients, both groups benefited, and there was a statistically significant PFS benefit for both of these groups. Whereas patients who were double hit, it's a smaller number of patients, and that means 2 or more high-risk cytogenetic abnormalities. So really with high risk, we're talking about 1 cytogenetic high-risk cytogenetic abnormality. Standard risk, we're talking about 0. For the double hit patients, we're talking about 2 or more. And in this patient group, there was a directional, you see those curves separating, they did not quite meet the threshold of statistical significance. So what Forte tells us is that dual maintenance therapy seems to prolong progression-free survival, at least for patients with standard risk and 1 high-risk cytogenetic abnormality. There are multiple other dual maintenance strategies that are out there: lenalidomide-bortezomib, len and ixazomib, len and dara. Remember, we just looked at the Perseus trial. There's also a study called the Cassiopeia trial, which involved dara, Velcade, thalidomide, and dexamethasone, compared to Velcade, thalidomide, and dexamethasone. And there were 2 randomizations in this trial as well. And dara-based maintenance alone proved beneficial for patients who had not had daratumumab as part of the induction. With the Perseus and Griffin trials, it's a little bit difficult because, like we said, there isn't much in terms of, there's no second randomization there. So if someone's getting daratumumab all throughout their treatment course, we're not isolating the effect of daratumumab plus lenalidomide at the time of initiation of maintenance. This is Perseus again, and we've already gone over this, so you remember what I just said. You can see down here, daratumumab is included all throughout, and then there's this decision point where MRD is assessed, and we decide if patients will continue on dara-rev if positive. If MRD negative, they'll stop dara, and dara can be reinitiated if you see MRD recrudescence or loss of response. We've actually already discussed this data in the initial section, so I'm going to move through it, and we'll talk about ARIGA. ARIGA is an interesting study. So ARIGA is a study of patients who did not receive daratumumab in the first as part of their induction, and patients who were MRD positive at the time of randomization to a particular maintenance regimen. And so while this study is informative, it doesn't necessarily meet all of our, it's hard to find a patient nowadays, or it's going to be increasingly hard to find patients who didn't receive daratumumab as part of their initial therapy. You can see that in this trial, patients are randomized within 6 months of autologous stem cell transplantation. They have to have better than a very good partial remission, and they have, as I mentioned, not to have been treated with daratumumab or isatuximab in the frontline. Primary endpoint is MRD conversion rate from baseline at 12 months after the initiation of maintenance. So we're looking at converting patients from MRD positive to MRD negative. And that has become an important endpoint in myeloma management, especially from a regulatory perspective. Secondary endpoints are PFS, overall MRD conversion rate, and sustained MRD negative conversion rate. And we do have some initial data from this trial, and basically the primary endpoint is met. So patients experienced a significant increase in MRD conversion rate, I should say, with daratumumab and Revlimid together versus with Revlimid alone. And you can see that this held true across patients achieving a complete remission, as well as throughout the intention to treat population as well. So there is a benefit to adding daratumumab in daratumumab naive patients at the time of randomization, at least in terms of conversion from MRD positivity, MRD negativity, at 10 to the minus 5. And so, some conclusions from this trial are that we saw more than a doubling of the MRD negative conversion rate by 12 months. You saw it across various different subgroups. There is also a signal here that dara added to lenalidomide quadruples. It really has an impact in terms of deeper levels of MRD remission. So talking about 1 cell in a million, the effect there is even more profound. It's amplified. You see deepening of responses as time goes on, and there weren't really any new safety concerns. And PFS data is not quite mature here, but we expect that there may be a PFS benefit to the dual agent maintenance. How long should maintenance last? This is a really cool analysis done by Charlotte Paulin, looking at that same Myeloma 11 trial. This was presented at ASH in 2022. And what they did in this trial is they took that Myeloma 11 trial that we just discussed previously, and they looked at patients who were on maintenance, and they essentially, in a really intelligent way, stopped the clock at various time points. They looked at the hazard ratio, with the additional benefit of continuing maintenance at various time points. And what was found in this analysis was essentially that patients, continued maintenance seems to matter, and this was lenalidomide-based maintenance, seems to matter up until about 4 to 5 years. And after that, you don't necessarily see an additive benefit. So there's some suggestion here that if you're not going to use an MRD, based approach, maybe 4 to 5 years. And again, like all of these trials, standard of care has changed a lot since the Myeloma 11 trial. And so we're not quite comparing apples to apples necessarily, but there's a signal here that perhaps between 4 to 5 years, if we're not adopting an MRD adapted approach, may be a reasonable time to think about for duration of maintenance therapy. Yeah, and so this was median duration of lenalidomide here was 28 cycles on the trial, and 45% of patients at the time of the relapse were still receiving maintenance. So here you go. The main overarching idea is that these data suggest that an ongoing PFS benefit is associated with continuing lenalidomide maintenance for around 4 to 5 years. And even in the patients who had sustained MRD negativity, we didn't put this data up. There was evidence for continuing maintenance for at least 3 years. So even if you hit MRD negativity in this trial, there was still some benefit in PFS out until at least 3 years. And there was, for those who were MRD positive, there was data to support continuing LEN until disease progression. So we say 4 to 5 years in general, but MRD has an impact here potentially. And if you're MRD positive at the end of 4 to 5 years, there's a suggestion that maybe, we should continue maintenance regardless. And I think that is the end of the presentation. Yeah, and so we also found out from this trial there was no additional hematologic toxicity, and we'll have more overall survival data. We should have more overall survival data relatively soon. And so commonly asked maintenance questions here are, should post-transplant maintenance be recommended for all patients? I would say yes. Lenalidomide is the standard of care for now. I think different centers do this differently. We sometimes use a second agent for very high-risk patients, although you can make an argument that we actually haven't seen that borne out in many good data sets. So lenalidomide alone or dara-len potentially, or len-bortezomib are used, but I think lenalidomide is the standard of care for now. Optimal duration remains to be seen. I think there are kind of two approaches. You either take the ASH 2022 data and you couple that with MRD, or you do something like MASTER, where you look at sustained MRD. Right now, treatment until progression remains a standard of care, but those two approaches are what we're sort of on the horizon. Like I was saying, for patients with high-risk cytogenetics, we consider lenalidomide plus bortezomib. That's based on an old trial, the HOVON 65 trial, or daratumumab, as we're seeing in some of the subgroup analyses from the more recent trials. And, should MRD status dictate maintenance therapy? I don't think yet. I'm not doing this yet, but I think it's close. And second primary malignancies are a relevant concern. The risk of, like I said, mortality from a second primary malignancy, at least with the data we have at our disposal, is outweighed by the benefit, the improved mortality in terms of multiple myeloma, in terms of the primary disease, at least for single agent lenalidomide-based maintenance. There we go. That was close to 10 minutes, I think.
Thanks, Lou.
Yeah.
I appreciate it so much. Lots of information there, lots to take in. So we've come to our last talk. You're stuck with me for the last one, but the questions keep pouring in, so I'm going to ensure that we have a chance to get to the vast majority of those. So thanks everybody for hanging in with us, and thanks so much again, Lou, for a great talk. There's a lot going on in maintenance therapy. So let's talk just a little bit about how we approach relapse and this notion that we've talked about since the start of this webinar, that we try to not save the best for last. We want to give our patients the best opportunity early on. We'll talk about some of the key trials and some of the new things like CAR-T and bispecifics. One of the reasons why we focus on what we do early on is that sadly with each line of therapy, there are fewer patients eligible for treatment later, partly because patients, sadly, some die, some just not able to go on with further therapy. And so what we do upfront makes a big difference in the long term. And so how do we make sense of this? When I started in myeloma, as we were joking, and Beth thinks that she's my age, but whatever. That we had all these, we only had one or two drugs. Now we have so many options. And how do we deal with those options? Well, I like to put it this way: there's no simple algorithm. We don't just say we always do this, then we do this, then we do that. We really have to have a strategy of using the different combinations and the different mechanisms of action that we have. We tend to think of sort of early and late relapse. So people in 1 to 3 prior lines of therapy, people are later than that. And we also think about what's called triple class refractory, the 3 main classes that we start with: the proteasome inhibitors, the immunomodulatory drugs, and the monoclonal antibodies. And when you get refractory to that, you're called triple class refractory. Some of the principles that I won't spend a lot of time on, but I think are just so important, even if I didn't show you any data tonight. The depth of response matters. We've heard that already from Lou, that even if MRD may not be guiding our therapy, we want to get as deep a response as possible. We have to respect the biology of high risk versus standard risk disease. And there's some situations we have to be particularly aggressive with high risk disease. We always have to balance efficacy and toxicity. It's one thing to get sick for a month or two, maybe after transplant, but as we put people on maintenance therapy long-term, for example, we have to really be careful as to what we're doing. I like the way Lou had commented about that, that sadly there are patients that can't even stay on lenalidomide maintenance. We want to make sure that we promote not only quantity, but quality of life. And as we learn, this disease is smart and it figures out what it's on and gets resistant to it. So coming at it in a different way with a new mechanism of action is really important. So when we use these terms, and I give this slide more as a reference and to explain it, when we talk about the disease coming back in relapse, or refractory, meaning it's growing while on something, these are the terms that we use. And when we talk about a line of therapy, it means a treatment you've had until the disease relapses. And you'll hear us using those intermittently. So that slide I showed you with the person holding up all the puzzle pieces, what to do, how do we make the decision? Well, 3 major areas guide us. What's the nature of disease itself? Is it high risk? Is it coming back quickly? Is it coming back slowly? The treatments themselves, what have they previously had? What toxicities do I think may come? What cost might there be to the patient? And then the patient's specific phenomenon, maybe the most important. What are their preferences? What are their own comorbidities or other illnesses they may have that may dictate how we treat them one way or the other? And also we have to remember that myeloma is not one disease. I wish everybody was like this green curve. They got into a deep response and stayed there for years before it wakes up slowly. More patients are a little bit like this blue curve, where we give them treatment, the disease breaks through and comes back. But unfortunately, every time it comes back, it's in remission for a short period of time. But there are people like this red curve that have the highest risk disease that really humble us. And so we want to treat them most effectively based on their disease. So those principles, as I mentioned, therapies change over time. And that's only because of clinical trials. And we've said it many times tonight, but we want to support our clinical trials because this is what has brought us to where we are today. We've had about 20 drug approvals in the last 20 years. And that's only because of the clinical trials we're doing. Outcomes like survival also changes over time as new therapies emerge. We've gone from 1 to 2 year overall survival to more than a decade now. But if one therapy did not work well, it doesn't mean another won't. We understand this biology of myeloma is complicated, and sometimes people see this one treatment didn't work. It doesn't mean other things aren't going to work. And I think this is such an important point. You know, even these curves that all three of us had shown to some degree, we use terms like overall survival or median progression-free survival. That's kind of the average of everything. And it's looking at groups and not necessarily the individual. And so you have to be looked at as an individual. I somebody gives my patients this analogy. I'll say, you know, if I count how many times it takes me to drive to my office in downtown Phoenix, you know, on average, it's about 30 minutes. But some days it might be 20, 25 if there's no traffic at all. But some days it might take 2 hours if there's a lot of traffic. And so there's such a variation in it. We talk about the averages, but the average don't necessarily apply to the person, just like that average may not apply to the exact drive I'm taking today. At any given point, there may not be a right answer. You know, I do a lot of expert opinions, or people come to me for further opinions, and we have to explain to them that this is a complicated area, and often there's not one simple answer. And so we look at the whole house of myeloma, as it were, and we have all these different categories and all these different drugs. I could bore you at length and rattle off every single clinical trial that's been done for all of these drugs, and you all be asleep before the end of the evening. But it is amazing to have this huge foray of drugs, and we'll talk a little bit about them, especially as we think mechanistically how they work, and we'll go through some of these as we go through. But it's really been amazing how we've leveraged the outside and the inside of the myeloma cell, trying to target it from the outside, but also target it from the inside. And the two that I'm particularly focused on tonight are the bispecific antibodies in the bottom corner. As I mentioned, the 3 drugs that we have, plus others that are coming, but also in the top left-hand corner, the CAR T-cell therapy. These T-cells we take out of a patient to teach them how to fight their own multiple myeloma. So the basics are the so-called naked antibodies, or the simple or the monoclonal antibodies, the drugs we've had for many years, the Darzalex, Sarclisa, and Implicity. They basically hook onto the outside of the myeloma cell and trigger the immune system to destroy them. The antibody drug conjugate, similarly, but it has that backpack I talked about, that toxin that it drops into the cell. Now, this is a drug that was removed from the market a few years back, but most of us strongly believe it'll come back in 2025 because we've had some very strong data around it. And so the question is Blenrep or belantamab coming back? Well, we saw in the DREAM7 study, so this was a trial that actually compared 3 drugs to 3 drugs, where we added belantamab to Velcade Dex with or without daratumumab, or daratumumab with Velcade Dex, and belantamab with Velcade Dex, and compared the two, and we saw really an impressive difference, both in progression-free and a trend towards overall survival. Similarly, with the DREAM8 study, this time we added belantamab to Pomdex versus Velcade Pomdex, and in both situations we saw the benefit of belantamab. So we do think this drug works really well, and we think it's coming back. The challenge with this drug still is that it has some issues with causing some blurriness of vision and some eye symptoms. I think we're getting better at understanding it. We just have to give the drug a lot less frequently. And then there are these bispecific antibodies. I mentioned before, they're called bispecific, because one arm hooks onto the myeloma cell, one arm hooks onto the local T cell, and sort of engages or activates or wakes up that T cell, says, hey, how you doing? You know, introduces that T cell into the myeloma cell so that it can directly destroy it, which is really quite an ingenious concept. And as I mentioned, we have 3 drugs already: teclistamab, talquetamab, and elranatamab, and we're waiting soon for Linvo to join the firm, and ultimately another drug called cevostamab. And then lastly, in terms of the mechanisms, is this CAR T-cell concept, where again, we take T-cells out of a patient, and through a very interesting manufacturing process, we basically stick on the outside of that T-cell a receptor that is specific for the multiple myeloma. That's where we get the word CAR. CAR is an acronym for chimeric antigen receptor. So we're putting a receptor on the outside that goes after an antigen. Antigen is the recipient of an antibody. So antigen is the thing that sticks out of the myeloma cell. The antibody is what hooks onto it. And these CAR T cells are remarkable. We have seen a response to CAR T that exceeds anything we've ever seen before. So before we saw bispecifics and CAR T, all the previous drugs I've talked about had a response rate between 22 and 32% in patients that had heavily relapsed myeloma. When we introduced CAR T, that literally tripled into the 75, 85, even 95% response rates. So it's very exciting. It comes with challenges. And of course, Beth shared with us many of those challenges, the challenges that we face immediately after CAR T and even longer. So I don't want to make it sound like CAR T or even bispecifics are perfect. There is nothing perfect yet in myeloma, but they have given our patients deep and durable responses and so much more time than they would have had otherwise. So as I described before, we tend to think of early relapse and late relapse. And sorry, the font got shrunk down here somehow. But in early relapse, we think about these drug combinations that we have, where if someone hasn't seen one of the drugs from those classes or hasn't seen any of the class of drugs, we mix and match between the daratumumab and isatuximab, between carfilzomib and pomalidomide, and now we have this new drug, relatively new drug, selinexor, which I think is very effective when used correctly, and we use those drugs in combination. Well, that's also just changed as well, because also, as Beth noted, we now have CAR T cell therapy as early as first relapse with cilta-cel and second relapse with ide-cel. And so one way of approaching it, and this was our friends at Mayo Clinic thinking, well, if someone is at first relapse is not refractory to anti-CD38, meaning they've not progressed on either daratumumab or isatuximab, we can divide them based on that realm, that there's still a lot of benefit from getting a drug like DRD if they haven't seen lenalidomide or Revlimid yet. If they are refractory to lenalidomide, then we have these other combinations. And if they've relapsed quickly with high-risk disease, then we might want to go directly to CAR T-cell therapy. Even though CAR T-cell therapy is approved at first relapse, we're not giving it to everybody for lots of reasons. And we know some of it is access, some of it is the potential risks associated with it. But we know those patients that have very high-risk disease and are growing back very quickly are probably the best to benefit from it. And so we do that whether they are refractory or not to CD38. And this was based on two really huge and important studies in myeloma. The first was with ide-cel, the KarMMa-3 trial. It compared giving that one-time infusion, and if we haven't mentioned that enough, I think it's important to remember, even though CAR T is a challenging process, it's one and done. Patients after CAR T go on to my favorite drug, as I say all the time, nothing. Every insurance company covers it. Every patient is 100% adherent to it. Patients, I love writing prescriptions for nothing. It's great. And these patients got ide-cel, and it was compared to the typical triplets that we use that I was commenting before. And these are patients that had at least 2 relapses, but 2 to 4 relapses. We saw that on average they stayed in remission about 13 months, whereas it was really only about 4 months for the triplets. And then soon thereafter, we saw the Carvykti trial, the CARTITUDE-4 study. This was even a little bit earlier, so 1 to 3 prior lines. So even patients that had just 1 prior line of therapy. And amazing, the patients that got the triplets this time had about a year of progression-free survival, but those patients who got the Carvykti was significantly longer, hasn't been reached, as we call it, meaning in this case, it's clearly over 2 years, probably over 2.5 years. So it's really remarkable to see this kind of impact even in earlier line, which is why we're using it. And so that's why I give you this sense of what our response rates were before with these other drugs. And now with CAR T and now with bispecifics, we've taken a big jump from the 20s and 30s to the 60s, 70s, and 90s. And I really do think this is the way we're moving in the future of multiple myeloma without giving too much detail. So again, borrowing from my colleagues where I previously worked at Mayo Clinic, when someone has had later relapse. So now it's not just first relapse, which we saw in the previous algorithm, but here, and again, notice it's not just one algorithm. It depends on a lot of different things. Is someone, triple class refractory? Have they seen everything yet? And we still have lots of options. One option I should just tuck in there at the very bottom, although it's not FDA approved, is if someone has, and about 15% of myeloma patients have this thing called translocation 11-14, a piece of chromosome 11, a piece of chromosome 14 are joined together. It gives the myeloma a bit of a different flavor of biology. We have a drug that seems to act on that pathway called venetoclax, and there's some other newer ones being developed. We may consider that as well. But as you can see here, there's a lot of use of CAR T-cell therapy when someone has gotten further on. And then once they've, of course, gone even more lines of therapy, that's when they may be eligible for a bispecific. They have to have had 4 lines to get to a bispecific. We showed you this briefly before, and Beth mentioned it, so I won't go into a lot of detail. But just as a reminder, CAR T-cell therapy is a journey. We've got to make sure people are assessed and they're candidates for it. We have to collect those T cells on day 1. We have to wait for the manufacturing. That could be 4 weeks, 6 weeks, sometimes even 8 weeks. And then a few days, 3 days before they get those cells back, we give them that, what I called before, the lymphodepletion chemotherapy, that sort of chemotherapy that just prepares their immune system to accept their T cells. They get their T cells back, and then we have to watch them closely. And some hospitals will still admit these patients because they can experience some of those reactions that Beth made mention of. And I've just tried to summarize them in the 4 big categories here of cytokine release syndrome, that immediate reaction, the neurological issues that we still don't fully understand, the low blood counts with all of these T cells attacking plasma cells or going after the myeloma cells, but they hit some of the good cells, and of course the risk of infection. In the early days, we sadly saw a lot of patients succumb and even die with infections. And so I think we're getting much, much better at managing those. And as we move lastly to the bispecifics, again, I've talked already about how these drugs sort of bridge between the T cell and the tumor cell. They bring the T cell close to it to activate it, to destroy it. We have these 3 drugs, which are really quite an amazing concept to be able to engage T cells without having to collect them before. So we can kind of give this right off the shelf. We don't have all that wait time that we see before. But they also come with side effects. They have similarly the CRS, the neurological things, the cytopenias and the infections, maybe not as dramatic for the CRS and the neurotoxicity, but maybe a little bit more we have to watch with the infections, because unlike CAR T, which is the one and done, these bispecifics are ongoing treatment. And I think we've already learned that we probably don't need to treat them as aggressively as we did before. We used to give the first bispecific, for example, teclistamab, every week indefinitely. Well, most of our centers now, after the first 8 to 10 weeks or 8 to 12 weeks, are dropping down to every other week, and maybe even several months thereafter dropping down to once a month. But these patients have to be watched closely. There's other viruses and other unusual infections that can happen. Most of our patients have to take an antiviral. Most of our patients are getting immunoglobulin or IVIG because their own IgG is not being made high enough to protect them infections. And some of these patients, we even have to keep them on certain kinds of antibiotics. So when we compare then CAR T and bispecifics, we see that they're both very effective. The CAR T is the one and done as opposed to an ongoing therapy. It's still typically starting in academic centers, although we're pushing towards doing more and more in the community. We tend to have more of the side effects of CRS with CAR T than we do with the bispecifics. So just a couple of final points around them, and I've really emphasized these enough, but I just like to make sure they're very clear that you have to have a conversation with your doctor about these side effects and what you may experience and how we overcome them. And sometimes they can be severe. I was in the hospital today with one of my patients who had really quite a dramatic reaction to his bispecific antibody, even though it was just the little baby starting dose, as we give it, step-up dosing as we call it. And so we have to be very aware of those things. On the other hand, I saw a patient earlier that day in clinic. She's had her deepest response to a bispecific that she's ever had with any treatment, and I've been treating her for 12 years. So these drugs really can be hugely effective. We just have to be obviously very careful as we use them. And then what do we do with patients who've pretty much seen all of these drugs before? We do have another bispecific antibody that has a different target, as we saw earlier. Instead of Right now, all of our CAR Ts and 2 out of the 3 bispecifics focus on BCMA. We have a different target, that GPRC5D target. And so we can use a drug called talquetamab, and Beth shared with us some of the side effects we have to manage. Sometimes we go back to something a patient hasn't had before, or maybe had before and didn't have for very long. If they haven't had selinexor, we definitely use it. And sometimes we use these more complicated regimens. Looking to the future, we have more coming. We've already talked about Linvo probably being the next one that we'll have availability to, but we have other bispecifics coming that even target a different antigen. Cevostamab looks at an antigen called FCRH5. We're doing CAR Ts that target these different ones and not just BCMA. There's a whole new class of drugs called cell mods, which are kind of like the next wave of the drugs that we had known as IMiDs, with thalidomide, lenalidomide, and pomalidomide. Now we have iberdomide and mezigdomide coming, and we hope to have those in the clinic in about a year or so. And then there are lots of other small molecules. I don't have time to get into them all, but just to reassure you that we ain't done yet when it comes to myeloma research. And this slide that you're probably nauseous from now, but just reminding us how much there is available in the myeloma community, how much more we're trying to do. Before I wrap up and go into the Q&A, I think it's really important to just spend a couple of minutes about clinical trials. Beth mentioned it, Lou mentioned it, I've mentioned it. What is this deal about clinical trials? Well, as I said before, research has brought us to where we are today. At the same time, no one wants you to be a guinea pig. Sometimes people hear clinical trials and they think, oh, I guess I'm kind of donating my body to science, right? Like, I guess I'm doing this to help other people. Let me tell you, you can be selfish. This is about you. This isn't about other people later. This isn't about even contributing to science, although you will be doing so. The primary motivation for someone going on a clinical trial should be for their own benefit. And that's what we do in myeloma. No one's expecting you to be a guinea pig. When we give people, as we'll show you, their treatment, at minimum, they are getting the standard of care. And so you've seen a lot of these trials compare 3 drugs to 4 drugs, or 1 drug to 2 drugs. The 1 drug is the standard of care. We want to see if as Lou showed to us in maintenance therapy, is 2 better than 1. That's how we do the trials. So someone is still getting the 1 drug. This is under very tight supervision, especially after the history of what we've seen, sadly, in the past, and how this has lost a lot of trust within the medical system and has caused irreparable harm through things like Tuskegee that we've all heard of and understand. But we're trying to turn that tide, and a lot of it has to do with very open, clear communication. So why would you even think about doing a trial? Well, often you have access to a new therapy that is not yet FDA approved. And that allows you to delay the standard of therapy so that we can give you more options over time. And as I've mentioned, it's not just contributing to the myeloma world in the future, it's for you right now. Sometimes there are financial challenges accessing things, and yet clinical trials can be available. But that has to be balanced with every drug comes with a risk. Every drug comes with the risk of not even working. And so those have to be considered. And so as we think about different phases of trials, I don't want to go too much detail here, but we start even before we come to humans, where we do studies in the lab and so on. I've been involved in very much of those kinds of studies, and I do a lot of phase 1 clinical trials in my clinic, where this is really where we're just learning a drug. We want to make sure it's safe. Safety is paramount in research. Phase 2 means we've tested the safety of the drug, and now we want to see how well it works. And phase 3 is when we see how well it works against the standard of care. And so it's worth having this conversation with your doctor, with your team. Are there trials available to you? We've already shared with you that at the myeloma website, you can go and look up all clinical trials in myeloma and look at through a search engine that is actually pragmatic. If you go to clinicaltrials.gov, you're going to find thousands of myeloma studies, and it's going to be hard to make sense of them. You come to the myeloma website, and as I mentioned, we partnered with Spark Cures, and they've worked so hard to curate and to properly prepare a system so that people can really look at the relevant clinical trials to them. But why do so few patients participate in trials? Well, often they're not aware, there's not access to them, there's a lack of trust. There's some pragmatic obstacles. It's 4 hours away and I can't drive there. Sometimes there are insurance challenges. And sometimes let me put it on us as the physicians, we don't offer it. what we've learned is that we need to build a strong relationship. And let me tell you, wherever you are in your journey, you building a strong therapeutic relationship with your healthcare team is going to improve your survival, whether it involves clinical trials or not. It's so important to have that. And if that doesn't exist, you may have to look to elsewhere, because it isn't just a window dressing. It isn't just bonus. It isn't just cream. It is very critical that you have a strong relationship with the team that takes care of you. I do a lot of work in this realm, and so it's important for me to talk about this because we need appropriate representation in clinical trials for lots of reasons. It's not about a number. It's not about meeting some metric. It's about saying 20% of myeloma patients in this country are like myself, of African descent. And yet, historically, clinical trials had 1 to 2, maybe even 5% of patients of African descent on trials. How do I know that that drug is safe and effective for my patient if they've not been involved in the trial? And there's lots of reasons for this, building on the basics of systemic racism, the social determinants of health, the sensitivity to medical professionals, and the previous misconduct that I discussed. And so it's incumbent on all of us. And you'll see us rolling out a brand new program in 2025 from the IMF about diversity in clinical trials, where part of that program is going to involve patients from historically underrepresented groups who have actually been on a trial, who are going to share their experience and share what they have been through so that others can hear it from them. So as I mentioned before, lots of resources available. You can call our info line. I know with some of the questions coming up, I'm going to be directing you to the info line, which you can call at any point, whether in the US and Canada or worldwide, with the numbers that you see on the screen, or just email us at infoline@myeloma.org. And also, as I mentioned, specific to the trials, if you go to our website at myeloma.org, it'll take you to Spark Cures, and you can do you can search clinical trials there. So with that, I'm going to stop and bring back our two wonderful guests. And I hope you've been eating your Wheaties in between, because I think we're up to about 65 questions now. We still have about 25 minutes, or a little under 25 minutes. So I'm very grateful for that. We've caught up a lot of our time. So let's dive into some of these questions and pick up from where we left off. So we ended talking a little bit about Linvo, and let's move on to the next question. If my friend is on steroids now, not started any treatment on therapy yet, and it's throwing her blood sugar levels like crazy, and she is diabetes type 1, what can she do about this? Well, Beth, maybe I'll get you to talk a little bit about Dex and blood sugar.
Yes, and thank you, and I love hearing your presentation, so thanks for sharing your knowledge. Dexamethasone is a corticosteroid. It tells your liver to make more sugar, and your pancreas can't keep up, even for people that don't have blood sugar problems. So the first thing we start to recommend for people that don't have type 1 or type 2 diabetes is just try to avoid carbohydrate intake, especially around the days of the medications. This is where it's really important for you to have a primary care provider in your back pocket. Your friend probably has a endocrinologist, so definitely making sure that they have knowledge that you're on the corticosteroids. This is exactly why we try to say less is more. I do believe there's a strong role for dexamethasone, and some people just need it to control their disease for whatever reason, but it can be a low dose. So we try to get to the lowest dose possible to control the disease and try to eventually get rid of that medication. But there has to be two-way communication with with the provider. Lately, they've been doing the patches. They have a patch that you can use your smartphone to continuously check your blood sugar. And so things have come around a lot recently. Many clinics will have dedicated nurses or pharmacists that can help you manage the blood sugar as well. So again, bringing in that multidisciplinary team and doing the best we can to help manage the blood sugar while we are treating the myeloma.
Thank you. Yeah, Beth, I mean, it's just such a sensitive topic. Obviously, we have so many questions to get to, but I'll also tell people that I had the privilege of writing a little editorial that should come out in the next couple of weeks called Down with Dex. And so we can talk more about how I think the role of dexamethasone is shrinking a little bit in what we do in myeloma, albeit very important. There's someone who's asked, a really tough question, and my heart goes out to you. She talked about her husband, who's a 72-year-old gentleman who was working in the yard and got quite weak in his legs, and had excruciating pain in his back. Turned out, obviously, that he had multiple myeloma. and then she's asking if there's an explanation, and it goes back to what we started with, that myeloma is a tough disease to diagnose. There's so many things that cause back pain. There's so many things that cause weakness. I'm just very sorry that it happened in this way, and I hope he's gotten good care and that his pain has improved and that his myeloma is under good control. So here's a question from Patrina that says, hi, good evening. I'm a 56-year-old Black female, and I'm currently in remission of myeloma, which we're glad to hear, Patrina. Congratulations. And I wanted to know if having celiac disease has anything to do with myeloma. Lou, do you want to comment at all about the connection or lack of connection?
Yeah, I don't think I know of a direct connection between celiac disease and multiple myeloma. We do know that part of the reason why myeloma may be more common in the Black population has to do with a lot with the immune system and autoimmunity, and there's a lot of interest in that topic, but I don't know of any direct connection. I don't know. Do you know, Joe? I'm not.
No, I think you've answered it correctly. I mean, I think we've always thought that maybe there's some connection with all autoimmune diseases, but we don't know a formal connection. And to reassure you, Patrina, it wouldn't change the way we treat you in general, meaning it's not like we would have a different treatment for patients that do or do not have celiac disease, but I hope your remission continues. Here's a question. If on maintenance and in remission, when should bisphosphonates be stopped for someone with extensive bone damage, but only one fracture at diagnosis? So Beth, do you want to comment about, we typically use bisphosphonates, the bone strengtheners early on, but once someone's in remission, longer term, what's your strategy at Cleveland Clinic?
Yeah, there's no clear guidance. So the International Myeloma Working Group has very clear guidelines to recommend the imaging and the detection of bone disease. There's also papers out to recommend about monthly for a year. Again, we give these medications to decrease your risk of getting a fracture, breaking a bone. Once you get one, then you're more likely to get another. But we also know that some of the newer drugs will protect you against future fractures based on how they work in the bone environment. The answer to the question is we're not sure. And if somebody doesn't have a lot of bone disease, we'll generally give about 12 doses, monthly for 12 doses, and then we're going to give it quarterly or stop depending on how good the remission is. There's so many different practice patterns, so just talk to your provider and see what their thoughts are. If you don't even have bone disease, though, there is evidence that we should be giving you at least a few. The one thing I would like to say before we stop talking, because I could talk for hours, so you gotta watch out for me, denosumab. There is some evidence from Mayo Clinic and who's the guy at Mayo Clinic, the endocrinology bone guy, recommends that we don't just stop denosumab. So if you've been on denosumab, it's a rank ligand, a little different than a bisphosphonate. If you can't just stop that because you can have a reverse bone modeling, that's extrapolated, I believe, from the osteoporosis literature. We don't stop it automatically in osteoporosis. It's recommended to give like a dose of zoledronic acid and then stop. I don't know what your guys' thoughts are on this topic.
Yeah, Lou, do you have any comments about, maybe actually, Lou, before you answer, let me just also toss this in as well, because question number 17 is in the same vein. My mom refused cancer treatment for her own personal reason, but she wanted Xgeva for bones. She lost her ability to walk due to bone destruction. I'm so sorry to hear that. Can bone modifying treatment like Xgeva or bisphosphonates provide the benefit to make her walk again? She believes she can walk again with this. So maybe you can just comment on that as well.
Well, first of all, I'm really sorry to hear that. That's a terrible situation. The first question was, do we, how long you need to use bisphosphonates for? Is that, sorry?
Yeah, I think that's a question. And also, do you just immediately stop?
With denosumab.
Yeah.
I do try to give a dose of zoledronic acid afterward. There is some evidence that there may be a transiently increased risk of fracture, and a fracture is about the worst outcome, one of the worst outcomes you can have in that context. I think it's good to remember that a lot of the literature around bisphosphonates and myeloma was from an era where our upfront therapies were a lot less effective. So I'm much more liberal about discontinuing bisphosphonates in patients who achieve a deep remission. That's different patient by patient. In terms of the question about Xgeva, I don't know that in the context of active myeloma, if there's no treatment of the underlying disease, I wouldn't say that it would help her necessarily walk again. It may either there was a suggestion with some of the bisphosphonates that they actually improved myeloma outcomes in people who were getting treated, with chemoimmunotherapy, but Xgeva alone could potentially help strengthen her bones in the short term and maybe prevent or delay further fractures. But I'm not sure that just the RANK ligand inhibitor by itself will help in terms of.
I completely agree. I mean, I think that's the key point, is that I think we respect when people refuse treatment for their cancer, and I understand that. But the sometimes I've said the heat in the room is because the furnace is on way too high. You can open the window and try and cool it down, but you got to shut off the furnace. The furnace here is the myeloma. The bisphosphonate may be opening the window to try and get that cool air out, the hot air out to cool it down. But we really need to ultimately treat the myeloma. Here's a good question, because we're running out of time, so I got to speed them up. Can your body eventually create healthy antibodies on its own? And the answer is yes. I mean, that is the goal. The goal is as you get rid of the weeds on the lawn, the good grass grows back. So the goal is that patients do restore that. Myeloma patients, likely have always some degree of immunocompromise, but not so dramatically that they can't go and enjoy life. And I had a patient the other day really wanted to go to a concert, and we were able to make it happen. And so I think that's really important. If you've had stem cell transplant, can you have T-cell transplant with myeloma recurrence? The answer is absolutely yes. In fact, the vast majority of our patients who were on the CAR T trials and even go through CAR T now have had a transplant. Although I will add that sometimes we have patients who are transplant ineligible, but are still eligible ultimately for a CAR T, because the requirements for CAR T a little bit milder. Hi, Beth. Anything newer than scrambler therapy to treat CIPN? Do you want to comment on Steve's question?
Hi, Steve. So no, I think some updates from the scrambler therapy that we're using at our institution that's very infrequently used at other institutions is it still does seem to have some benefit for myeloma patients. I wish that we had some breakthroughs in peripheral neuropathy treatments, but unfortunately we do not as of this time that I am aware of. I did start combing the ASH abstracts. The American Society of Hematology meeting is going to be coming up next month. The abstracts were just put online last week. And so I will look for some hot updates and circle back with you. Dr. Joe, Dr. Lou, I don't know if you know of any updates in groundbreaking therapy with peripheral.
Not just yet, but I think there's always ongoing work, and we'll be looking forward to it. So here's a question. I've read that Dara-Rev in maintenance can push patients to MRD negative at a faster rate, but is the rate that you achieve MRD negative critical to your overall survival or PFS? So Lou, I don't know if you really want to jump into that one. I think you've pretty much answered it in your discussion.
Yeah, so I think you remember that responses deepen over time. The most important, in my opinion, prognostic biomarker when you're looking at MRD is whether or not the MRD is sustained or not. I think that is far more important than the trajectory to arriving at MRD. Remember, when we check MRD, we're using a small amount of bone marrow aspirate, and myeloma is heterogeneous. So there are aspects of the test itself too that may go into this, but overall, I would aim for MRD sustainability as opposed to rapid achievement of MRD. It's probably better for it to be rapid than not, but it's more important for it to be sustained.
Great.
Slow and steady wins the race.
Absolutely.
I think.
How often do people get eye problems from the chemotherapy? So in general, it's not something we see dramatically with most of our therapies, with maybe the exception of dexamethasone, which we know prolonged dexamethasone can cause cataracts, and that is one of the reasons why we're working hard to reduce dexamethasone. And then when it comes to belantamab, the majority of patients actually in the earlier trials did experience some kind of eye symptom, whether it was blurriness of vision, dry eyes. This was confirmed often on eye exam as well. I think the new way will ultimately giving belantamab, in my humble opinion, probably once every 12 weeks, we'll probably likely see a lot less of that. We've talked so much about bone disease. It's great. There are a lot of questions bone disease. I recently heard a talk that all myeloma patients should be on a bone strengthening drug, even if they have no bone involvement and good density. The recommendations we have are that for at least the initial period of time, because we don't have perfect measures of bone disease, and chances are every myeloma patient has at least some thinning of their bone. We debate a little bit how long that's necessary. Typically, it's for 1, maybe up to 2 years of a drug, typically a bisphosphonate therapy, and then that can be discussed, as we said earlier. What West Coast institutions can you recommend for care and treatment? I live in a small community currently. I'd encourage you to write or call to the info line. We keep the names and locations of so many providers along the West Coast. I, of course, am affiliated with City of Hope, and we have other amazing places along the West Coast, depending where you are, and we can help you with that. Okay, let's keep rolling here. Does CAR T-cell therapy have the same risk of secondary cancers as stem cell transplants? There's a tough one. Maybe Lou, I'll get you to answer that one.
We don't know, but there was an early signal in CARTITUDE-1. So 9 patients out of 98 developed a secondary malignancy in that trial, predominantly hematologic. That's a really, really high number. We're not quite sure whether that was related directly to the CAR T, partially because of when the timing of those malignancies. So that's an area of open investigation. Generally speaking, I talk to my patients who are going to CAR T, to look at that. I make them aware of that data. We haven't seen the same kind of signal with earlier line CAR T yet, or with ide-cel in particular yet, but we're certainly watching for it. So I would say to be determined.
Great answer. I think that was very balanced. Someone's asked a question about coming off of steroids. They've been on 2 years. They're also on Revlimid and Revlimid, and their numbers started to go up. So they went back onto the steroids, and the numbers came down a little bit. And that's good. I'm glad they've come down, but let me suggest that's probably not going to be the definitive answer. If your disease wakes up while on Revlimid, with or without Dex, a little bit of Dex may help temporize for a little while, but I think a discussion has to be had about what would be the next course of therapy, because chances are the disease will grow. Obviously, we can't replace your care provider here tonight in those decisions, but I would have a bit of a discussion around that. If I wanted to get a second opinion, sorry, go ahead, Beth.
Can I just say super quick? So our practice patterns in Cleveland, and I think I know where this is coming from, there are some providers that, especially if you're balancing the fitness, the frailty, patient preferences, it's, I agree, but I know that there are some providers in our area that might recommend that, but we are now changing our practice patterns and more likely recommending to change to a more effective agent. So I agree. I just wanted to put in my 2 cents about that.
No, I think that's very well said. If I wanted to get a second opinion, do I have to get entire records? Well, it depends on the clinic. I mean, it is helpful to get records. Very often now, we don't have to do a lot of it because more of us are using a common medical record. So that can be discussed. I think you'd have to discuss that with the provider. I think you'd commented about City of Hope, and they're using the Epic. We're using Epic, which captures most of those patients. In cases, do you prefer DARA or ISA? I can comment on this partly because I helped develop isatuximab back in the day. I mean, they're very similar drugs, to be very honest. They're very similar in their efficacy. We've shown that giving one doesn't necessarily overcome refractoriness to the other, so we tend not to do them sequentially. And I think a lot of it has to do with what their provider is comfortable with and what's available there. We routinely give daratumumab now subcutaneously, so that sometimes is more convenient, although we're giving isatuximab now over shorter periods of time. So that can be discussed, but I wouldn't necessarily favor one over the other. I think they have a lot of similarities. Here's a question. In Perseus, DARA is continued in maintenance, and even though DVRD is the standard of care, DARA is not available in maintenance. How does the patient continue to get DARA? Obviously, it's going to depend on the scenario, but as I think Lou pointed out very nicely in his talk, that strategy of continuing DARA up to 2 years and somewhat MRD guidance, that may not have been fully embraced by the myeloma community yet, but in situations where I've wanted to continue DARA into maintenance, we have been able to obtain insurance approval. So I think that's something that should be pursued by your physician. Is there anywhere for a patient to obtain MRD testing if not offered at their treating clinic? And I think it's a great question. I think the simple answer is typically there are ways of doing it if that treating clinic can communicate with, there are labs that will take the sample and do it elsewhere and give the results. So even if the local lab is not available to do it. All right, we've only got a couple minutes left, but let me try and toss a couple of these questions in. We're so many great questions here. Oh my goodness. Here's a question that says, high-dose cyclophosphamide is used for CAR T conditioning, if so, or obviously to collect stem cells. If someone has allergy to cyclophosphamide, is there a good alternative? Beth, do you want to comment on that?
So cyclophosphamide is an alkylating agent. I think it's important to use for harvesting stem cells in some specific situations. Nowadays, we have drugs to help us harvest stem cells. We don't have to use cyclophosphamide anymore. If you are allergic to cyclophosphamide, I would ask what would that be? The allergy. If you're using similar drugs for lymphodepletion, we have like a bendamustine and cousins to drugs. So again, what is the allergy? What was the side effect if you're giving it, and why are you giving the drug? And so having that conversation with your care provider is super important.
Excellent. Here's another great question from Lisa. I've read articles that Kyprolis inhibits the activity of osteoclasts and potentially has a bone strengthening effect. If so, is it feasible for a patient to have fewer treatments of bisphosphonates if they are on Kyprolis? Fantastic question. I was actually a little bit involved in some of that work in trying to understand it in the early days. I think very pragmatically, although there's some evidence for it, we're not sure it's enough to say that someone shouldn't still get the bisphosphonate therapy or continue it. Obviously, if someone's having complications with bisphosphonates, that could be pursued as a potential, another rationale for backing off on it. But I think in general, we're still doing that. I think part of that activity that Kyprolis is just the way it works in benefiting a myeloma patient. And so I'm not sure that it's a recipe to stop or to reduce the number of bisphosphonate doses. I know we have so many questions here, but I think what I'm going to tell people before we wrap up is a couple of things. A lot of these are great questions that I want to be able to answer. And some of you know, if you follow the IMF on our YouTube channels, you'll know, or even on our Facebook Lives, you'll know that I do a lot of videos. Sorry, my face is out there so much, but I do a lot of videos. And one of the dedicated segments I do are answering questions that were asked online that we didn't get time to answer. So we catalog all of these questions that you put in the chat box, what are we at now? 68 of them. And I'm sorry that we can't get to them all, but I will do my best to get to them as much as possible on one of our Ask Dr. Joe Anything Facebook Lives or some of our videos that we post on our YouTube channel and on other social medias, where I try to answer a whole series of questions, typically 1 minute or less for each question, and we cover another 10 to 20 questions. So be on the alert for that. Also remember that we have the info line, as I've mentioned, and the info line is both a phone line and an electronic line. We have real humans covering it that want to help you. So please reach out to us and we'll do our very best to help you as we go forward.
And Joe, don't forget about Milo, because you can type in these questions to Milo too, and it'll track the website.
I was just about to say, and don't forget Milo. So thanks for the lead in, Beth, because we want to make sure that we're leveraging that. AI chatbot is amazing. And we do have it narrowed to all the resources on myeloma.org. So we do trust its answer. But obviously, if you ask it, other things outside of myeloma, it won't be able to answer. For those who are in the region, in the area here where I live in Scottsdale or in Phoenix, we are doing a regional community workshop this this Saturday, November the 16th, and you can learn more about that on our website as well. And as we started, remember, please do fill out our survey. We want to hear from her. We want to know how helpful this has been to you. We very much appreciate your feedback, very much appreciate your sponsors, as we've mentioned before, and we're just really grateful that you've joined us tonight. I want to thank thank Beth Feynman. I want to thank Lou Williams for not only their expertise, their dedication to myeloma patients every day in their work, but taking out a whole evening to spend with us to do this evening has just been particularly gratifying for me. And I'm so thankful for each of you and appreciate you very much. Thank you as an audience for listening. We hope you have a great night or day whenever you're listening to this rebroadcast, and hope this has been helpful in your myeloma journey. Thanks so much.
Thank you.